Good morning. My name is Khalid J. Qazi. I'm professor of clinical medicine at University of Buffalo School of Medicine and Biomedical Sciences, and former program director for medicine for Catholic Health System here in Buffalo, as well as international coordinator for the Government Medical College Srinagar Alumni Association. It's really an honor and a great pleasure for me to welcome all our listeners and viewers to this important and timely medical seminar that's focusing on what we have come to know as COVID-19 pandemic. It truly has ravaged cities and towns and countries across the globe and continues to wreak havoc as we speak. We will hear more about that from our esteemed speakers. May, as you know, is Mental Health Awareness Month. We have assembled an excellent panel of medical experts across 3 continents for this accredited seminar exploring the wide-ranging impact of COVID-19 on mental health, especially in Kashmir. That's going to be our focus. 6 experts and researchers will share their experiences during the first session that will be moderated by Professor Maqbool Dar. In the second session, the experts will entertain questions from the audience in an interactive session. And that session will be moderated by another stalwart, Professor Mushtaq Ahmad Marghoob. And both these moderators are extremely qualified and experienced faculty from the University of Kashmir with local, national, and international repute. And we are truly honored to have them with us this morning. As required for the accreditation of such programs in the United States, I need to make a brief statement regarding that. The seminar is accredited by, it's accredited to provide continuing medical education credits for physicians. It has been planned and implemented in accordance with accreditation requirements and policies of the Accreditation Council of Continuing Medical Education of the United States, through the joint sponsorship of this program with Islamic Medical Association of North America and the Government Medical College Srinagar Alumni Association. The Islamic Medical Association is accredited by Accreditation Council of Continuing Medical Education to provide continuing medical education for physicians, and has designated this particular program for 3 hours of Category 1 credits. Physicians who might be interested in CME credits are instructed to claim only the credit that commensurates with the extent of their participation in this particular program. And for the speakers or moderators, please start your presentation with a statement regarding any conflict of interest you may or may not have with any pharmaceutical industry or any other entity. And there will not be question and answer after each presentation, but that will be entertained in the session number 2 after we break from the session number 1. With that, let me introduce the Seema Bhat, who is a graduate of Government Medical College, Srinagar. And after arriving in the United States, Seema went through a rigorous training program in our training program, and followed that with fellowship at the world-renowned Roswell Park Cancer Memorial Institute, and has been going on the academic ladder ever since, with accolades, as she had started back in her medical school in Srinagar, Kashmir. So it is a joy for me and a pleasure for me to hand it over to Seema. Seema, it's all
Sure. Thank you, Dr. Qazi, for that kind introduction. These words from you sound music to me. Welcome, everyone, and welcome to this webinar. As Dr. Qazi said, COVID-19 pandemic, which is in its second year now, has impacted every aspect of our health. And mental health and well-being, of course, could not remain shielded. With acute illness, bereavement, lost jobs and wages, and social isolation, the impact has been unprecedented all around the world. And as you heard, May is Mental Health Awareness Month, and we are using this opportunity to learn about the impact of this pandemic on mental health and how our physicians from Kashmir around the globe have been managing this. Government Medical College Alumni Association presents the Mental Health Webinar, COVID-19, a ravaging disaster, global experience with focus on Kashmir. As Dr. Qazi described, this is a CME activity. The program is chaired by Dr. Qazi and co-chaired by Professor Mushtaq Margoob and Professor Mohammad Maqbool. A brief overview of the program: we will have 2 sessions. In the first session, we'll have lectures by 6 esteemed faculty from around the globe, stretched around 3 continents, USA, UK, and from Kashmir itself. This will be chaired by Dr. Mohammad Maqbool, who's currently head of the Department Psychiatry in Kashmir. The session 2, there will be a brief break between session 1 and 2, 5 minutes break. Session 2 will be a panel discussion and interactive session chaired by Dr. Mushtaq Margoob. And here the audience is requested to direct their questions on the QA, which is at the bottom of the Zoom link on your right side. Please do not use the chat function, use the Q&A function for that. Just going over the brief objectives of our program today. Our objectives are to understand the impact of COVID-19 and the pandemic on morbidity and mortality, to analyze women's mental health and COVID-19, data sharing, quantitative and qualitative shifts in mental health, experience in rural setting, COVID and changing trends in substance abuse, and stress and bereavement. So before we start, few housekeeping tips and recommendations. Please mute your microphone during the program and switch off your video. Please use the chat function for any questions to the panelists if you have any technical issues. For Q&A session, please use the Q&A button on the right side. If you have any technical difficulties, please refresh your browser. Otherwise, shoot us a message on chat, and our IT department will try to help you out. Please use the link provided at the end of the program in the chat box to complete the survey and claim your CME credits. And a gentle note to our speakers: please watch the clock. Don't force me to watch it. So with that, I will open the first session, and it's my pleasure to introduce Dr. Mohammad Maqbool. He's currently head of the Department Psychiatry in Government Medical College, Srinagar Institute of Mental Health and Neurosciences in Kashmir. He completed his MD in Psychiatry from Government Medical College, Srinagar, did his senior residency from Government Medical College, Srinagar, and joined faculty there in 2005. He has authored several papers in both national and international journals. He has organized a number of conferences and seminars. He has played a vital role in getting the Center of Excellence designation to the Institute and General Hospital Psychiatry Unit in Kashmir. His area of interest include mood disorders and spirituality. Welcome, Dr. Maqbool, sir.
Thank you, Dr. Seema. So let me start. It's common and normal for individuals to feel stressed and worried in response to any disease outbreak. Am I audible?
Yes.
Okay. Specific stressors particular to COVID-19 pandemic are rumors and misinformation, closure of schools and children's activity spaces, travel restrictions, possibility of or actual physical isolation and quarantine, deterioration of trust in social networks, avoidance of health facilities, risk of onset of new and relapse of pre-existing mental health conditions. Common symptoms of other health problems can lead to fear of infection. Then there can be social stigma like discrimination towards persons who have been infected and their family members. Now, there has been some surveys in Kashmir. Let me tell about which findings which I have in front of me. A survey done during this outbreak of COVID-19 from Kashmir showed that more than 2/3 of healthcare workers working in COVID designated hospitals were more emotionally exhausted, felt increased sadness, or were irritable. Another survey report showed proportion of anxiety and depression symptoms to be 38 and 19% among healthcare workers working in COVID designated hospitals respectively. Then a survey report on COVID-19 survivors from our institute also revealed 44% and 61% of survivors experienced anxiety and depressive symptoms respectively. Then a good number of persons showed PTSD symptoms. Then about 82% were obsessed with fears of contamination and equal number had compulsive hand wash. And total deaths related to COVID-19 in Jammu and Kashmir are more than 3,400. 5 doctors died in COVID-19 in J&K in last week only. And number of healthcare workers, including me, got COVID infection. So I think without wasting much time, today we are having a CME on COVID-19 and mental health, and I will be moderating the first session. We have 6 speakers, and every speaker has 15 minutes, and I request all the speakers to stick to time. Thank you, and let me invite the first speaker. Our first speaker is Dr. Mudasir Firdausi. He is consultant psychiatrist and honorary at St. George's University of London, UK. He did his MD from our institute and trained further at Mudasir Hospital, London, and is a member of the Royal College of Psychiatrists, London. Dr. Mudasir will be talking on COVID-19 and mental health global perspective. Dr. Mudasir, please.
Hello everybody. Thanks for having me today. I'm glad to be invited, and thank you all for joining. As you see, my subject of the talk is a global perspective. I think it's hard to fit in 15 minutes, but I will try my best. So I don't have anything to disclose, no conflicts of interest here. General overview. So I will try to speak briefly about the effect of pandemic on the mental health of general population, then a little bit about how it affected the frontline health workers, and also its effects when people have active COVID infection, and what are the long-term neuropsychiatric consequences of the pandemic. So I think we all have seen, this is one of the newspapers here, not the famous one. Sounds like panic news, 10 million people are facing mental health crises. I think we see similar news from all over the world. And there's a lot of talk that most of us are probably unwell now because of pandemic, and there's lots of mental health problems going to crop up, or they have already done. Looking at the data, I think it's still too soon to see what is happening. It's hard to quantify, and every country, there are thousands of papers have come out, and I think it's hard to actually guess how the numbers are doing. There was early last year, there was a survey here of Royal College of Psychiatrists, which I'm a member of. So I think most psychiatrists thought that there was like almost 43% increase in urgent emergency cases. And then some were predicting there would be a tsunami of the cases. Did it really happen? This was recently in Nature, which is well respected. So you can clearly see comparison between 2019 and 2020, just anxiety is kind of more so in the US, 42% compared to 11% in 2019, and I think UK doing a little bit better there. This is one of the independent sector charities here who wrote a long report. So they predicted there would be like 10 million people, in nutshell, additional people who will need help from mental health services because of the pandemic, due to generally anxiety, depression, and other problems. This is one of the largest household surveys which has been happening from many years and decades now. UK longitudinal household survey. So they surveyed around 50,000 people and using GHQ scores. So if you see these cohorts, this is the current cohort, 2019, and this is from 2014. You can clearly see the shift in all age groups. This 16 to 24, 25 to 34 of mental distress. Clearly, all age groups are affected almost equally with such kind of stress. And these are the individual scores around GHQ. I think the worst ones, even the sleep, difficulties concentrating on problems, confidence, general happiness. So everything seems to be affected as per this survey. And there was another survey from the Office of National Statistics last year, which suggested around 69% people have some kind of worry, and more than 50% feel either anxious and some feel bored. And I think if you look up the UCL study, which is online, and I think when I picked it up, it was a while ago. Again, majority kind of referring to anxiety and depression in relation to various problems, usually loss of household income and other issues. This is a quite interesting website if you are interested to have a look at. And this is from CDC in US, who surveyed around 5,000 people, and at least kind of 40% responded with something: depression, anxiety, PTSD, substance misuse in last year, and suicide around 10%, which is fairly significant. What are the potential reasons? I think I don't have to tell you, I think you all know this, that probably social isolation, change in routine, job losses, boredom, conflicts in families, and there's lots of reports of domestic violence. Then some people resorted to drugs and alcohol. A lot of news coming through, which is again happening at the minute, did create a state where people became more anxious, are not able to sleep, can feel more depressed, things like that. And if you look through the data, I think the general sort of reports in general population are usually mostly anxieties on one, insomnia, depression. And if somebody has already had a problem, the symptoms would be worse. Many people have relapse. I think we have evidence of new cases of mania, psychosis. And if you see case reports, I published one case report recently around that. And increase in drug and alcohol misuse. So I'm going to go through a few of the recent kind of hardcore data, mostly meta-analysis. I have to be honest, I know most of my friends have published on this from Kashmir, from other places, from here. I have done some work, but I I'm not using that. The reason being there are so much publications around COVID from everywhere, that in thousands and hundreds of thousands, and I think it's hard to sort of. So I have actually tried to sort of look at the major meta-analysis which have been published most recently, I suppose, in terms of some of these symptoms and disorders which I already referred to. So if we look at anxiety disorders, this recent meta-analysis of 43 studies around the world, so they found that anxiety disorders were 3 times more common than previously. Usual prevalence is around 7%, and usually the anxiety is worse at initially at the outbreak, which I think we all know when the pandemic started. We were all more anxious and more worried, more in females, more in younger people. Not sure how married people get more anxious there, and it's probably arguing too much. Social isolation, unemployment, financial hardships, and you name it. So those were some of the factors which, so essentially the message is that anxiety is the most common kind of difficulty which has kind of cropped up since pandemic. Looking at depression, there's another meta-analysis, 12 studies, prevalence from 8% to around 48%, and pool prevalence was 25%. So this is again 7 times higher than the usual prevalence, which we see pre-pandemic, quite significant there. If we look at PTSD and psychological stress, another meta-analysis, 14 studies, so pool prevalence was around 24%, and psychological stress 24%, which almost 1 in 4 has significant stress because of pandemic. And this is again way beyond the usual prevalence of PTSD, I should say. Who is worse off? So this is another meta-analysis of 50 studies. So they found that clearly the patients who suffered from COVID-19 were the worst off psychologically, then healthcare workers, and then general public. Usually poor sleep, stress, psychological distress, insomnia, PTSD symptoms, anxiety, and depression were the most common in these 50 studies. Children, briefly, I think this another meta-analysis of 15 studies, around 23,000 children in this, commonly anxiety, depression, more than 30%, 40% irritability, challenging behaviors, which is very significant, 79%. I think those with having children would probably, and significant fear of COVID-19 in children. And similarly, in caregivers, that was parents would be anxiety and depression respectively at 50 and 27%. What happened to perinatal and mothers? I know we have a talk later, so this will be discussed further. 8 studies, around 8,000 women of anxiety and depression. So I think significant anxiety was worse, but depression scores were not as bad in this case. And if we come to health professionals, this was a meta-analysis of 7 studies which compared health professionals to other professions. And again, the anxiety is sort of topping the charts here, 13% with 8.5%, and depression after that. Besides, I think significant people had somatization and insomnia here. This is a significant, let me go back. A significant study, a cohort study which was published in Lancet Psychiatry of around 62,000 COVID patients. I think they screened 69 million health records, out of which around 62,000 were COVID positive. So out of that, the people who had a psychiatric diagnosis the previous year had a higher incidence of COVID-19, and this was seen as an independent risk factor to catch COVID. Simply having a mental disorder is a risk factor for COVID, unrelated to physical health. And in absence of any past psychiatric history, COVID-19 infection was again associated with increased prevalence of psychiatric diagnosis in following 2 weeks to 90 days compared to other infections like influenza, other RTIs, or even surgical problems, fractures. So hazard ratio was again highest for anxiety, insomnia, and dementia here, which is significant. Briefly about when somebody gets infected, I think mainly if you see ITU, you will see delirium, catatonia, psychosis, other neurocognitive or behavioral problems. And this is the data from those who have COVID or who were admitted. 72 meta studies in this meta-analysis. Most common anxiety at 40%, then insomnia, then anxiety, memory impairment, depression, confusion. And in post-illness stage, again, I think sleep is the major factor many people are talking about. This says 100%, which I'm not actually sure. Traumatic memories, fatigue, memory impairment, and delirium in ITU in 65% and 25% who subsequently died out of this lot, quite significant there. So what are the long-term consequences? This is again a one big study in Lancet, around 80 million health records where this is the UK one. Primary cohort who had COVID were compared again with other respiratory tract infections and influenza. Out of this significant number of 230,000 cases of patients who had COVID. So I think this is worrying. This says around 1/3 of those people who had COVID would develop some kind of neurological or psychological disorder in next 6 months. And more so people who are in ITU, they will have a first diagnosis around 25%, which is very significant and worrying. But this is a very busy slide, sorry for this. Just wanted to sort of make sure. So if you look at all these diagnoses from intracranial hemorrhage to Guillain-Barré syndrome to dementia to psychosis, I just want to make a brief comment about vaccines here, because most people think that if they take a vaccine, they will have a very serious side effect. And this is what can happen if you get COVID. All these disorders are very much far worse than having some of the side effects of vaccines, even a clotting disorder, I assume. So is the news all bad? Probably not. So this study, which is you may have heard of this Psychological Research Consortium, which is ongoing from UK and many other countries, Italy, Middle East, India. I think Dr. Majid is part of this. So they looked up some of the data in waves in March, and then in April 2020, and then July. The conclusion is that the psychological response is heterogeneous. Everybody doesn't respond same way. And overall prevalence of anxiety, depression has remained stable. So I think they are arguing that probably whatever the studies are saying is probably not that correct. And usually in the wave 2 and 3, there was less PTSD. I think they are basing it on that people got used to it, they accepted it, and they're supporting easier. And they have come up with this idea of a resilient class here. Which is a good news. So although there was an increase, but they think that with ongoing pandemic, the numbers are not actually increasing. They remain stable, or they're actually dropping. So I think I will stop there. This is my email address and contact. These are here some of the references. Thank you very much for listening to me. We'll catch up again in the Q&A session. Thanks very much.
Thank you, Dr. Mudasir. Thank you very much for finishing in time. Now our second speaker is Dr. Arshad Hussain. He is Professor, Institute of Mental Health and Neurosciences, Government Medical College, Srinagar. He played a vital role in getting Center of Excellence at our center and is one of the renowned psychiatrists. So Dr. Arshad will be talking about COVID-19 mental health experiences from Kashmir. Arshad sir, please.
Yes, thank you very much. Good morning, good afternoon, good evening, depends upon which part of the globe you are linking in. And assalamu alaikum to everybody. Thank you, Professor Khalid Jahangir Qazi, for inviting us. And thank you, Dr. Seema, my friend, classmate, for making it possible for us to talk today. We know that in March last year, when COVID started, probably it started in December, and here we had the first case in March. There was COVID Alua. That became a priority everywhere. And we did not have, all other services actually were not a priority and were not thought to be priority. This is about my disclosures, we are done. And even though people people were actually talking about mental health problems, we at this point of time know that most of the people think of this pandemic as a dual pandemic, and we regularly talk about dual pandemic and sometimes even a triple pandemic in terms of the COVID pandemic, the mental health problems, and the economic deprivation, which actually happened because of the COVID, and all the three flaring each other and in a vicious circle, actually leading to each other. That's the understanding now, but probably that was not the understanding at the starting of this pandemic. In fact, in our part of the world, the problem was very, very different. We had almost complete disruption of mental health services. Not only here, I understand that worldwide that happened. That's how the understanding was. And if you look at WHO data and look at all the mental health services, you'll see that there was almost 60% decline in almost every service for mental health, in spite of the fact that 1 year after now, we are thinking of it as a dual pandemic. Indian scenario was no different. There was complete disruption of services, whether outpatient, whether inpatient, whether drug addiction services, child psychiatry services, almost all electroconvulsive therapy services, almost all services got affected. This again, one of the papers which was done by one of our friend in PGI, wherein he found the disruption of mental health services in almost all parts of India. In March, probably in 18th of March, we had first coronavirus case detected in Kashmir. And the second day we had a visit of the administration to our hospital. And the visit was with the purpose that, this was a new build hospital, a very good building on site. And this seemed to be a good idea to change into a COVID hospital, because that time, nobody could have thought that mental health services will be so important even during the COVID. So the district administration came, and we, on our behalf, Principal Medical College and all of our faculty, logicalized, rationalized with the administration. Luckily for us, this administrator actually, we were able to convince, and he let us to have mental health services at that place, and he excused Institute of Mental Health from being made a COVID hospital in Srinagar. That day, he had actually visited about 5 buildings. 4 of them were actually changed into COVID, and others were spared. And rest, was history then. Most of you will be aware of Institute of Mental Health and Neurosciences, Kashmir. It's the same place wherein we had a mental asylum first, which then graduated into a psychiatry disease hospital, and then a department of Government Medical College, and now we have an Institute of Mental Health and Neuroscience built at the same place. You know that this is about an only long care residential facility for psychiatric patients who are a long distance, whole Kashmir and in Jammu areas as well. We do not have residential facilities for psychiatric patients anywhere else. In fact, admission facilities are also limited to this place, even in pre-COVID era, as I understand that there are some of the general hospital units now coming up at schemes and in the district hospitals which are trying to actually do admissions as well. But in COVID era, this was the only facility which had admission facilities available. As we were rationalizing with the administrator at that time that mental health will be needed, mental health needs will go up. I myself did not know that why was I saying that and how was I saying that? Well, all outpatients in surgery and any other departments got disrupted, completely stopped. Our outpatients started increasing. Our increase was almost doubled from 200 to 350 every day. And as we were now non-COVID hospital, we had to actually take care of these patients. We had decided to actually run these services. We did very simple things, which might seem to be very, very simple. With science coming in COVID now, lots of learnings from last more than 1.5 years now. Everything we did seems very very, very small things. But at that point of time, when there was no science backing you, you were not knowing what to do, what not to do, how to run OPD services, these seemed to be very huge decisions at that point of time. First, the decision of actually running an OPD 350. Everybody will call us and say, oh, are you running an outpatient? Is that really an offline outpatient? And we started with the usual, as was happening that time, that, you will do this infrared temperature, you will do symptom checklist. That happened for some time. It couldn't be carried on, as you know, but some things we carried on. For example, we will not see patients without masks. We made it mandatory that every patient comes in our hospital outpatient with a mask on. And, hospital and non-governmental organization chipped in, they provided us those masks. We used our open lawns and solarium to keep these patients at distance. Once you will enter these places from 10 to 4, we try to maintain as much distance and kept these open. And with new researches coming on, the aerosol infectivity of COVID, that seemed to be a very rational decision at that point of time. Inside the consultation chambers, initially, some of the doctors, most of them actually started wearing PPEs, but we soon gave it up and we started wearing masks, and sometimes double masks with a face shield. And that's how we did it. And only in terms when we had to do a physical examination, for that, which was the spray room, there the people, the resident or the senior resident will go with a complete PPE and start actually seeing the patients. This was kind of OPD which was taught by Dr. Maqbool Saab as actually in March last year. And you will be pleased to know that now CDC and lots of other guidelines do speak about open outpatients. He started seeing patients like this, even though I did not see that time. Now I have actually started on off days. In other OPD days, I do see in the regular OPD, but another off day, if a patient comes, this is how we see it. But Dr. Maqbool actually could think of it in last March is something very remarkable. Inpatient was something which was very, very important for us. We know that we had residential 40 patients, and we also knew from studies from Wuhan, from studies from UK, studies from US, that most of the badly affected places with COVID were the institutional cares. And we were really worried about our institutional care, that what will happen to this. And we in that, we made certain recommendations to our hospital. We did not put any new patient in these wards and made very few exceptions during full air. Probably till December, about 5 exceptions to that rule. And in those 5, we made it sure that they are first kept in isolation for about 5 days. Then an RT-PCR is done, and after that, they are actually put in the ward. For the wards per se, we used to regularly do after every 3 weeks, the kind of wards we have with common bathrooms, with all people without masks, the beds very, very close to. And we thought of these wards as pools. So what we'll do is that after every 3 weeks, we'll do an RT-PCR survey of our ward. We'll do 1 or 2 random RT-PCRs, and we thought at that point of time that this will tell a story of the whole ward. Seemed very unscientific. Some of the people really challenged that at that point of time, that it's very unscientific. But our January survey of these 42 patients, sero survey, actually says that we were doing actually the right thing by doing those RT-PCRs, because our sero surveys still, we had seroprevalence of almost 0 in all the closed wards in December, when the first week was almost over. So we continued monitoring our wards like that. And another decision we had to make about electroconvulsive therapy decision, which was sort of an accident. I think that one Wednesday or Friday, passed in that we were trying to actually arrange our hospital, how to do the outpatient, how to do inpatient. And I suddenly realized that electroconvulsive therapy actually was done. And we thought of very simple measures actually at that point of time. There was not a lot of research which had come. Most of the people were thinking that electroconvulsive therapy is an aerosol generating procedure, but we thought of electroconvulsive therapy as one of the very important therapeutic modalities in psychiatry, which is life-saving. So we thought of having it open. And we again did very simple measures which are now actually backed by research. We opened doors and windows of electroconvulsive therapy room. We kept minimal staff there, very, very minimal staff there. We kept patients, in spite not in the waiting room, but in the open for waiting. We kept most of the patients admitted for the electroconvulsive therapy period. We didn't clear one RT-PCR because that time rats were not initially available, but as soon as in June's rapid antigen testing started getting available, we started doing actually rat tests before every session. And I tell you that during this 1 year, this was really a life-saving procedure. At least 2 little catatonia, at least 10 or 15 catatonias, and lots of people with major depressive disorder with severe suicidality were saved, and they were lives saved. And I really think that the decision, we took a rational decision of continuing with electroconvulsive therapy at that point of time. As all of us know that, as we had become a global village, as we changed it from homosapiens to homo deus, in everything, we will use social medias to talk to our friends, we'll use WhatsApp, we'll do video chats, but I don't think there was in subcontinent, and particularly in our place, there was enough use of media, social media and tele in actually providing medical services. In spite of that, we know that most of our medical services are unavailable to common people still. People have to come for distances for the services. But they're not gone a lot of popularity. But here is when we thought that to lessen the burden of people actually coming to our OPDs, because when they started filling, we started telepsychiatry services. And I tell you that again was a very rewarding of nature, because lots of people will debate about that telepsychiatry services take away empathy, take away all the things which actually form therapeutical answers. But I found it very fulfilling. In contrast, I'm not saying in contrast to normal services, but in contrast to how we see patients now, with face masks, with shields. Many a times patients will really like to do that, the cultural stuff of ours, touch you, hug you, or, all the things which patients are very commonly do in our OPD, and see your face, which they were not able to. But with telepsychiatry service, I think there was lots of satisfaction in many of such patients. This is our telepsychiatry data. It's in publication currently. You could actually see this usual stuff. We were not seeing, as we know that we were not seeing many COVID-related mental health issues in the first wave. I was always talking about it, even the world was actually buzzing and bumming with lots of research coming out COVID-related mental health issues. But our data, both offline and online, was seeing significantly our own patients and very small number of people which were COVID-related mental health issues, and prime among them were COVID-related delirium. We were seeing some people who had OCPD-like, obsessive-like features lifelong. They were decompensating. We were seeing old OCDs who were in remission. They were actually coming back, and we were seeing some autonomic activity post-COVID in some of the young people, but not very significant post-first wave, as I'll talk about later about the second wave. I think this was one of the first articles which came about the stigma and COVID. In fact, I had actually written it, I had elaborated it, I had sent it to JAMA, but I did a mistake. I had sent it to JAMA as a commentary, and I did a mistake. Actually, it got published in a local vernacular press before JAMA accepted it, and had told me to actually elaborate it as an editorial. But that time it already was published in local vernacular press, so I couldn't actually follow it up. But we wrote about stigma, the kind of stigma which the COVID is getting in March, and I equated it with tuberculosis and leprosy, that we really need to fight stigma to actually fight COVID. We as a department actually did lots of advisory during that period, and one of the advisories which became very famous in Kashmir was called Dar-Moderator Darbar. All Kashmiris will relate to that. This was our cultural way of actually telling people to keep social distance, and Dar-Moderator Darbar became a very popular advisory at that point of time. We at the postgraduate department, and we as a department never wanted that our education will get affected. We used lots of, almost all platforms to actually continue teaching our postgraduates, do case presentations. Zoom became a boom in our department for education, particularly. I think PGs, our PG's exception in all the departments in medical college particularly, and particularly all over, that they probably had more learning during this period. They could get more time actually to discuss cases than they probably ever had. And we also had faculty from other places also sharing their sharing material with our PGs during that time. Actually, all the research we did during that, some of our postgraduates did present that as well, and send it for presentations at various points, and some of that is in publication phase currently. We continued with consultation liaison services. In fact, both inwards as well as outwards. Being part of the greater medical college, we had 2 facilities which were COVID, one SMHS and one at CD Hospital. We continued consultation liaison services, them online as well as offline. We continued our consultation liaison services inwards towards our patients, because many of these residential patients had endocrine consultations to be done, cardio consultations to be done, and we saw tele-psychiatry helps, telemedicine helps to actually overcome that difficulty. And many a times we did not take patients to these hospitals, probably protecting them from getting infected with the COVID. One of the remarkable things was our addiction services by our addiction unit. Dr. Yasir will talk in detail about that, because he was somebody who actually carried that. And this was the only inpatient addiction service which was running in whole North India at that point of time. In fact, probably in whole India, inpatient service. All public health inpatient service for addiction patients were actually gone, and this was one of the addiction services which continued. Dr. Yasir might actually talk about it in detail later on. We, at the point when all departments were going to government medical college with, to run OPD services, they will go with demands. To run other services, they will go with other demands. We try to actually make our hospital self-sufficient in everything, including testing, including actually doing almost everything related to COVID activities started happening within our institute. This is offline consultations we did till more than 70,000 offline consultations were done from March to December, which is remarkable, which is much more than any medical department within the valley which has actually done that work. But I'm finishing, sir. I'm finishing. But we also celebrated a little bit early. We thought that the first wave is over, and probably we are winning. And this is one of the international media which carried this story of us winning the war. We didn't say it, but he thought that we won the war, but we knew that this is the battle only won and not the war. And then came the second wave. And whatever optimism I had during the first wave of very little mental health morbidity and mortality, has been taken away with the second wave. Last 6 weeks of both offline and online consultations have been significant mental health morbidity because of because of the COVID. All kinds and types of that we are seeing, because probably of a sudden surge in the mortality and sudden surge in the morbidity, which is not letting the regular cultural resilience mechanisms to help people actually cope. With this, I'd like to conclude. One, that while we ran COVID services, initially we thought that all other has become non-essential, which was not true. And probably mental health was very, very vital and important. And probably we took wiser decisions of keeping the mental health services on and help people during these times. And I still think, because COVID has not gone nowhere, we still need to actually concentrate on developing services, non-COVID services of all other departments, and helping people in other areas, because mortality and morbidity because of them could be unseen during this period, but might be significant. Thank you so much for listening to me patiently, and sorry for actually having 2-3 minutes past my allotted time.
Thank you, Dr. Arshad. Thank you, Arshad sir. So I'll be inviting our next speaker is Dr. Majid Shafi Shah, Consultant Psychiatrist, Health Services, J&K. He is one of the most busy psychiatrists of the Valley and often starts OPD at 10 a.m., which may go up to 5 or 6 p.m. So he'll be talking about COVID-19, experiences of rural psychiatrists in Kashmir. Dr. Majid Shafi, please.
Hello, Assalamu alaikum everyone. Thank you, sir. Thank you very much for a nice introduction. I am Dr. Majid Shafi. I am a consultant working currently at District Hospital Pulwama.
Doctor Saab, I have a request, please stick to the time.
Okay, sir, I will try it. Yes, I will try it. Yeah. The name of my presentation is Experience of a Community Psychiatrist, view from rural Kashmir. Conflict of interest. There is no financial liabilities of any kind related to this presentation. No presentation done on this topic before. Data not presented anywhere. And I am working as a psychiatrist at District Hospital Pulwama since more than 5 years. Working in District Pulwama actually from last 5 years. Pulwama has a population of around 0.75 million as per the latest projections, and we have to cater District Shupyan as well. And so our center caters a population of 1 million. And this is the only major mental health facility for these two southern districts. These are the visuals from the hospital during the COVID times, District Hospital Pulwama, and our mental health center, which is a separate building. This was essentially a major COVID facility of southern regions during this time. Mental health setup under normal circumstances. We have a team, a psychiatrist, it is me, and then we have a very good team of, we have program manager of district mental health program. We have program officer, which is sometimes on, sometimes off. We have a clinical psychologist, psychiatric social worker, and a record keeper. This is a very, very hard-working team, and they maintain meticulous records since last 4 years. We have counseling support from Doctors Without Borders, which are known by their acronym, French acronym MSF, and they also provided us during this COVID. They provided us medications worth 1 million Indian rupees, and we also liaison with some local NGOs at state level NGOs. This is working under normal circumstances. We have 3 OPDs. Our OPD usually starts unusually at 9 a.m. to 5 p.m. sometimes without any breaks. So usual footfall is 150 patients per OPD, and we have 2 intervention days where we give modified electroconvulsive therapy, transcranial direct current stimulation, cranial electrocurrent therapy. We are also ketamine clinic running for resistant depression cases, and LAI long-acting injection clinic. We have psychotherapeutic interventions, addiction treatment clinic, and detailed workup. 2 days are reserved for this. 1 day is reserved for District Disability Board, and on all other days we cater to emergency calls and liaison psychiatry, even sometimes on Sundays. And this is data footfall in our OPD since last 4 years. This year-wise, the first year we have around 8,000 because that was the year we started registering patients, and since then every year, including the previous year, we have been seeing around 4,000 new patients. This is incidents. Here we don't count the follow-ups. On 20th of March, we decided to stop our mental health OPD, the physical one, but we continued with the virtual one. Emergency mental health services were continued, including long-acting clinic, but other interventions were stopped, and we shifted to telepsychiatry mode. And this was actually from our social media page of DM District Mental Health Unit Pulwama. This picture, we advised people to stay at their home. And we tried to connect, and we gave them an option of connecting us with around five cell numbers, including a landline of ours. This was a mental health advisory bus issued by us. It was primarily inspired by the advisory issued by the IMHANS, which included the culturally appropriate measures like Dar-Moderator Darbar, as Dr. Arshad did talk about this. And then we continued our effort to keep patients at our home, and usually I used to receive around 100 to 200 calls per day during this time. During April and May, it was our season of visiting quarantine centers. Around 31 quarantine centers were set up in the district, and we visited almost all of them. And it was a season of telepsychiatry as well. This is a quarantine center visits when initially the PPE kits were scarce, so we managed with a ragtag PPE kits, but we managed to visit every quarantine center. But at the same time, we try to engage our people through our social media team, and we are available to them. And then even somebody has an say acute psychotic outbreak, he can visit us in our OPD. and the patients on a long-acting injection clinic, their care was continued, and some of them were injected, and we sent our nurse to their homes actually to manage them. And I again mentioned this Doctors Without Borders, they provided counseling support to us. And actually, this was acknowledged by the administration, and also came in the local dailies that they named this our landline number as Spoon Health Line, and this on 25th that we have managed around 2,700 patients by that time. And at the same time, we were connecting with the people with the periodic advisories. And but by the end of these months, we had kind of quarantine fatigue because our quarantine visits never used to yield much, except 1 or 2 patients whom we could have connected virtually as well. And we, at the same time, we issued an online self-assessment questionnaire, which was primarily based on PHQ sets. We already had a standardized Kashmiri translation of the same, and we put it in Google questionnaire form for the general public. And we issued periodically educational videos from our social media handle. And in June and July, we resumed our OPDs with caution. This is actually a transparent barrier between me and the patient sitting on the other side. And at the same time, we in the committee we could notice people dying of supposed heart attacks, and obviously COVID began to take a dangerous turn in terms of double pneumonias. And August and September, that was peak of COVID in Kashmir as well. Isolation duties, I was put on isolation duty for mildly symptomatic ward. This was a time of loss and grief. Some of our mental health team members turned out to be COVID positive, although mildly symptomatic. OPD was stopped again, and emergency mental health services were continued. I lost one of my friends and colleagues at District Hospital Pulwama. He was an internal medicine specialist, and he succumbed to COVID. Initially, he was admitted in our hospital only, and then after some time, we shifted him to Sikkim, but unfortunately, he lost the battle of life. In October 2021, we opened up again physically. OPDs resumed again with the caution, but there was some relief in COVID numbers. And our mental health day celebrations were lackluster this time, except for we issued some posters and nothing much. And November and December is traditionally a moody season in Kashmir. We see a jump in our OPD visitors, and we started gearing up for work and number of patients. But patients became lenient with mask wearing. We had a difficulty in making them understand to wear mask at least in the OPD during the consultation. This is our mental health team during this time. And January and Feb, we had a peak of OPD work. There was vaccine hesitancy in general public. There was continued cases of sudden deaths due to heart attack. And I noticed a syndrome of a combination of panic, doctor shopping, and increased hematocrit in some of my patients. By March 2021, there was peak of depression. And the maximum number of depressed patients I have seen in my OPD, incidents. And there was a start of a resurgence of COVID, but season of leniency and tumult was continuing. And by April 2021, second wave was well established. Masking in general population became more accepted, and conspiracy theories regarding COVID were now only with die-hard conspiracy theory fans. And in 2021, I was again put on isolation ward duties, but this time for actually severe patients. All clinical management decisions lie with me for the 24 hours. For the 24 hours I am on duty. Mental health team maintaining COVID data of the district, COVID-19 data of the district, my mental health team, and the season of telepsychiatry started again. And we again issued our numbers. We are trying to be available to the people, and only thing which we are continuing is long-acting clinics physically. All other services are interrupted, including modified electroconvulsive therapy. And this is actually me on my first duty. I got rest only after 12 hours, and round actually lost at 10 hours. I was so confused. I ended up being a internal medicine specialist for the day. This is actually the data from Jan 2020 to March 2020. Actually, earlier, anxiety, depression, and primary headaches are actually the three primary disorders which present from my OPD. But I am seeing a gradual shift to anxiety than depression since last 1 year. Earlier, for the 3 years, depression used to be predominant by 3 to 4% over anxiety. But now we are seeing more anxiety, and much of it is actually panic disorders and a syndrome, recent onset syndrome of doctor shopping and health anxiety, not actually amounting to somatoform disorder. If we'll compare it to the previous data, you could see actually just jump in the number of patients of anxiety and depression. Not that huge jump, but again, anxiety there's more jump than in case of depressive patients. This is the finer details of this. That in the initial period of pandemic, our interventions, ECT and then TDC stopped, but we resumed them now. Again, they are stopped. For sometimes these are the quarantine center visits where we saw actually 2,746 people in quarantine. They were seen in groups, not individually, not possible. So sorry, these were the calls. And we saw around 1,600 patients, not individually, but in the groups. This again a breakdown of the data we saw during this time, the number of patients. And there are some observations from the quarantine center data. We don't have meticulous data as we have in OPD. Less than 10% of the people in quarantine centers do express significant distress, which we have seen. Only 3% were qualifying for mental health diagnosis. Most of these 3% had previous contact with mental health services. They already had mental health. They were already suffering from mental health condition. Obviously, I told you the assessment was done in a group of 20 to 40, and exact data not available for proper analysis. And then observation from our telepsychiatry clinic, more than 95% callers were recipients of mental health services previously. And most of these were patients from our center only, from the Pulwama. Most calls were about continuation of the care. About this online questionnaire, I told it is based on PHQ SATs, which is actually based on PHQ 9, GAD for anxiety, and PHQ 19 for somatoform symptoms. We already had a Kashmiri translation at our center, which is standardized but not validated. And we tried to, we copied the Urdu version from a Pakistani study. We had 460 responses. Most of these responses were the employees of health department and administration. Males accounted to 82%, and the age group of 18 to 40 were 80% of the people were from this age group as expected, and Pulwama residents, 75% of the people were Pulwama residents. We have scoring like green, orange, and red because that is how different containment zones were labeled at that time. And 80% scored green. That means they didn't require any active intervention at the present. Only 13% were orange, where there was advice to wait for 2 weeks, 1 to 2 weeks, and then administer this questionnaire again. If they turn red, they can contact us. Of the red who contacted our helpline, most were the cases of the people with previous or current contact with mental health services. Some empirical observations. Increased recurrence and relapse of depressive disorders, anxiety disorders, and BPAD. Increased case of health anxiety, increase in incidence of syndrome of panic plus doctor shopping, increase in people presenting with grief. I will take just 2 minutes. Yes. Then there was a syndrome of panic attacks, doctor shopping, and increased hematocrit. These were essentially, this is the first case which presented to us. It was a male, 26 years, non-smoker and PhD scholar. He had typical panic attacks, and he was investigated excessively. And on evaluation, we did find an increased hematocrit, discussed with an internist, and we advised a phlebotomy. And phlebotomy resulted in quick relief in this patient. So then subsequently, I saw around 5 to 10 patients. I have data actually of these patients. They were typically panic attacks. They were evaluated excessively. There was increase in hematocrit, although hemoglobin of 16 and 17 is not abnormally high, but we are not used to seeing such hemoglobins in Kashmir. And most of them actually were relieved by phlebotomies, and incidentally, none of them had ever had symptomatic COVID, but all of them had antibodies against COVID. That means that they had got COVID, and probably their hematocrit has increased, and which has contributed to these symptoms. Take home points: mental health services are significantly affected during current pandemic. Technology is a support, not solution. Pattern of mental health disorders changing in community. In investment in manpower development and mental health services, the need of the hour. These are the pandemic readings for the psychiatrists. The first one was, they say coming events caused their shadow before. It was published for the first time in May 2019, Psychiatry of Pandemic, a mental health response to infections outbreak. The second and third book, they're from the Imhans. This is a logo of our mental health, and I thank you very much for bearing me, and I have to rush through this long presentation. I'm really sorry for taking extra time.
Thank you, Dr. Majid. Thank you very much. Now our next speaker is Dr. Samreen Shah, Assistant Professor, Department of Psychiatry, Michigan State University, Michigan. She completed her residency from St. Joseph Mercy Health System and has 7 years of experience in adult, geriatric, and addiction psychiatry. She'll be talking on impact of COVID-19 on mental health of women. Dr. Samreen, please.
Thank you so much, Dr. Maqbool. Thank you, Dr. Qazi, and the organizers for giving me an opportunity to speak on this wonderful platform. Assalamu alaikum, everybody. My name is Samreen Shah, and I'm going to be talking about the impact of COVID-19 on the mental health of women. Just no conflicts of interest for me. So just like all of us know, and our speakers earlier mentioned, that the last 1 to 1.5 years has turned our lives upside down. It would be safe to say that the worldwide outbreak of COVID-19 has completely changed the modus operandi of all segments of society. So while some pandemic-related stresses affect almost everyone, there are many that are specific, especially to women, and that's what we're going to talk about today. So let's try to understand the pandemic's effect on women's mental health. What makes them more predisposed to vulnerabilities? And then let's talk about what strategies we can adapt to prevent and treat these mental health consequences in our women. I would like to start by talking about the gender influences on mental health effects of the COVID-19 pandemic. We all know that the male sex has had higher rates of infection, higher mortality rates, but it is the female sex that is more heavily associated with behavioral reactions to the pandemic. Studies done in China during the pandemic found that the female gender is associated with higher self-reported levels of stress, anxiety, depression, or post-traumatic stress symptoms. Women, in fact, have a higher prevalence of risk factors, which are known to intensify during pandemic-like situations. Women tend to worry more about the health of their families or about losing income or the risk of exposure to coronavirus as compared to men. Women are disproportionately responsible for the majority of the household, whether it is childcare, elder care, and this is a global phenomenon, not just in the developing countries, whether you talk about modern societies, primitive societies. This is just a global phenomenon that women have a lot on their shoulders. Women also experience pandemic-related stresses specific to their reproductive functioning more than men. So the areas of impact include, but are not limited to, preconception and fertility issues, pregnancy, postpartum, parenting, domestic violence. All of these things affect women's mental health, even if we talk about outside the pandemic situation. And interestingly, the pandemic has affected these factors in such a way that it has had an automatic effect on women's mental health. Let's talk about the preconception and fertility issues. So approximately 45% of pregnancies in the United States are unplanned, unintended. The numbers have gone up during the pandemic. The answer is simple. Why? And the answer is simple, that because there is limited access to contraception during the current situation, attempts of avoiding going to the healthcare facilities, or cancellation of procedures for both birth control, for say insertion of an intrauterine device. If we look at the pandemic, if we look at the COVID numbers, say in Kashmir right now, how many women are comfortable or would be able to go to their OBGYN clinic and get an intrauterine device inserted? Very unlikely. So on one hand, there is increase in the number of unplanned pregnancies. And then on the other hand, because of unclear effects of the pandemic, of the virus on the developing fetus, and limited therapeutic options available or limited resources available, many couples have had to face the difficult decision of whether they should go ahead and plan a pregnancy or should they postpone. So to quote an example, a study was done in Italy, and among the survey participants who wanted to conceive prior to the COVID-19 pandemic, 37.3% no longer did. And the reasons cited were economic concerns and concerns about how the virus is going to affect her pregnancy. Another group of women that has really been hit hard is the women that had to pause their infertility treatments. Some of them were nearing the end of their reproductive years, and that has created havoc with their mental health because there is so much uncertainty. They don't know when to go ahead. So talking about pregnancy. Now, we all know that the perinatal period is a time of high vulnerability to mental health problems among women. 1 in 7 perinatal women experience increased anxiety, depression, or stress. So the COVID-19 has increased the fear among women. It has also brought about a reduced sense of control, as there is very limited definitive data available about the effects of the COVID-19 on pregnancies. So studies clearly indicate that the pandemic-related stressors are substantially elevating perinatal mental health challenges. A study of 4,124 pregnant women in China compared the EPDS scores before and after January 2020. So this was the day it was announced that the SARS-CoV-2 can be transmitted from human to human. And what were the observations? Compared to pregnant women before the announcement, pregnant women after the announcement had been made, these women had higher overall EPDS scores, had greater likelihood of scoring above the cutoff for probable major depression, had higher scores of anxiety subscale, and some of them even were endorsing suicidal thoughts. 2 more studies were conducted in Canada in 2 different groups of women, 1 pregnant women, one was 1,754 number of pregnant women. And again, they saw that the women almost were twice as likely to report symptoms that met a criteria for diagnosis of depression, anxiety, or even substance use disorders. Another study that followed kind of had similar results. So fear of childbirth in any woman can be heightened when she is deprived of family support, when she is unfamiliar with her medical team because she has not had enough antenatal visits, or when she is worried what, once she delivers, is her baby going to be separated from her. And unfortunately, the pandemic has brought all these situations in so many women's lives. And again, then there are no uniform guidelines pertaining to the assessment and care of pregnant women during the pandemic, which in turn is leading to significant distress in women. Another very crucial time in the life of a woman, the postpartum period. Let's see how that is getting affected. Now, a year and a half back, probably, these questions would be, nobody would think about these questions. But today, almost each and every woman who has recently delivered or is about to deliver is faced with these questions like, is my newborn more vulnerable to COVID-19? Is the virus transmitted through the breast milk? What if I cannot find formula or diapers because of that lockdown? So we know that social support is protective against postpartum depression. Support may be in the form of reliance on family, friends, or hired professional help. Before the pandemic, these were the things that were bringing some relief to new mothers while they were dealing with hormonal changes or sleep deprivation. And now, because of the pandemic-related stay-at-home orders, most of the new mothers have lost that support, and they find themselves juggling multiple roles with limited help from outside. Another thing that people globally have been faced with, and it is the pandemic parenting. So almost 1.2 billion students globally have been out of schools. Parents have reported feeling anxious, agitated, fearful, or increasingly depressed as they have to juggle between homeschooling and remote work. And guess who the main burden is on? It is the mother. Because as I mentioned earlier, the bulk of responsibilities for even childcare depends on the mother. So another thing that has shown a drastic increase during the pandemic and has devastated women's mental health is the increase in domestic violence. So as the world is being told, hey, stay at home, this is the safest place for you, for many people, home does not represent a safe place. In fact, it represents the least safe option. And these are the victims of intimate partner violence, especially women. The contributory factors include limited access to resources and social supports, increased stress due to job loss or strained finances, and increased use of substances. All these have led to an increase in domestic violence, and women are at the receiving end. So data so far indicate a significant increase in domestic violence globally. If you talk about Italy, Spain, France, Brazil, China, all the countries have reported a significant increase in the calls to emergency support services for women, some up to the point of almost 3 times compared to the pre-pandemic era. So when we talk about the impact on women, the Kashmiri women deserve a special mention because in addition to having to face the pandemic, there's a lot going on in the background which they are dealing with on a day-to-day basis. So we all know that the history of Kashmir Valley has been vivid with decades of violent conflicts and militarization. On top of that, it is a deeply ingrained patriarchal nature of the society that is affecting women a lot. For Kashmir's women, the COVID-19 induced nationwide lockdown came at a time when the valley was already experiencing months of residual restrictions from the abrogation of Article 370. The restrictions included heavy military deployment, night curfews, communication blackouts, closure of markets. So basically the pandemic combined with the strengthening of the pre-pandemic restrictive measures has made it extremely difficult for the women women living in that region. Gender-based crimes such as rape, torture, sexual assault have been a part of Kashmir's conflict. However, the upsurge in domestic violence against women in the current COVID-19 scenario has been described as rather alarming. Due to the lockdown, like in other places in the world, even Kashmiri women are trapped with their abusers, with nowhere to go to, no access to resources. It's important to notice that the Women's Commission was shut down in August of 2019. I repeat, the Women's Commission was shut down on August 2019. So the victims of domestic violence in Kashmir no longer have a dedicated avenue working solely for their assistance. As per the government social welfare department, So many rapes and molestations were reported in J&K during the first month of the COVID-19, which clearly showed an increase in the numbers from the pre-pandemic times. And it is believed that these are underreported numbers, mainly for two reasons. For fear of society, and secondly, there is so much confusion of where to report these incidents after the closure of the Women's Commission. Decades of living in the climate of conflict, crisis, and fear has had its psychological impacts on the women in Kashmir, with many of them suffering from depression and constant anxiety of not knowing when their husbands and sons would return, while the others are grieving over the loss of loved ones. According to the Kashmir Mental Health Survey reports of 2015, we can clearly see that it is the women who have more incidence, prevalence of depression, as well as anxiety-related disorders as compared to men. And then the COVID-19 has further had a detrimental effect on their mental health. And it has added another layer of fear of being infected by the virus, exacerbated financial insecurities, locked them up in their homes, and then limited their development opportunities as well. Now, in addition to this, add the ongoing communication blockade. So women in Kashmir, unlike the women in the rest of the world, can't sit at their tables and surf the net and learn about how to combat the virus, or how to speak to their loved ones in distant places. And this is further causing worry and distress among them. How can we help? The answer is not very simple. One size doesn't fit all. However, small measures that we take, small and big steps together, can help us to relieve some of these concerns. Simple things like reorganization of time and responsibilities. Within the home, establishing a structured routine, acknowledging one's feelings and feelings of others, practicing self-care, getting professional help. Proactive outreach to vulnerable groups of women could lead to prevention or early detection and prompt intervention. For pregnant women who may need to undergo labor and delivery without a loved one present, childbirth education can be adapted to include more stress management techniques and can be delivered online. Social support is a key factor, so that should be enhanced via online platforms like telehealth visits or online support groups. Parenting that has become so stressful, agencies like UNICEF offer parenting tips that should be looked into. For women at risk of intimate partner violence, maintaining an up-to-date information about available hotlines, shelters, family courts could be life-saving. We should consider this pandemic as an opportunity to build stronger, more resilient societies that would bring relief and hope to our women. We can take examples from history where such crises have been used as opportunities to improve gender equality. I would like to conclude by saying that we hope that this pandemic will help to recognize the major role of women at home and at the workplace, which has most of the times been ignored. The UN recommends allocating special resources to protect women. Women should be at the center of policy changes and collecting more data about women to analyze the impact of pandemics on women. And I'm sure if these things can be brought into practice, it is definitely going to benefit women and their mental health all around. Thank you very much.
Thank you, Dr. Samreen. Thank you very much. Now I'll be inviting our next speaker is Dr. Abdul Majid, Professor and Chairman, PG Department of Psychiatry, Sikkim Medical College, Hospital, Srinagar. He is one of the renowned psychiatrists of the country and ever busy in conducting conferences and CMEs. He'll be talking on stress, stigma, death, and bereavement amid COVID-19. Dr. Majid, please.
Thank you very much, sir. Thank you for a kind introduction. And the title that I'll be talking about is Stress, stigma, death, and grief that is not new to any part of world now. We have seen conflict for 30 years, but this COVID is a global phenomenon. And I would like to thank at the outset the organizers, Professor Khalid and Dr. Seema, my batchmate, and all other speakers, and importantly, my two teachers, Professor Margoob sir and Professor Maqbool sahab. It's always joy to share the panel with you and Arshad, who is my batchmate as well. It's always lovely to have people like you and others in the panel. So the disclosure is that I don't have any conflict of interest with any company for that matter or any other agency. So we all call it a novel disaster, but it's different because it is a new disease which our generation at least has not seen. We have seen it almost 100 years ago, and recently we have not seen it. So it's an invisible enemy, and they say that 1 gram of virus has literally devastated whole of the world. Apparently, unlike other disasters like earthquake and floods, everything seems to be in place on the surface, whether it is buildings, roads, and business establishments. But this COVID has really literally eroded everything inside out. People normally come to each other's rescues during devastations and during these disasters, but this one has been really a tough time for relatives, friends, and well-wishers who could not come to the rescue of their loved ones. Our health sector, as you can see, and the mighty Europeans and Americans crumbled, and so are we in a state of despair right now as far as health sector is concerned. Our economy, which Dr. Arshad talked about, is in shambles and business establishments are closed. Education has taken the biggest hit. And most importantly, many of us have lost our loved ones. And this has been complicated by non-availability of beds. Oxygen shortage has been in news for a long time now. There is shortage of medicines, and you can see the horrible scenes at the cremation grounds, and burial crisis is there, whether there are the dead bodies piling up in hospitals, and you have lake of fires as well. So this obviously, keeping this in background, will have a lot of psychological and behavioral impact, as has been known earlier for other pandemics and disasters, and same does apply for this thing. So you would have stress as one of the most common psychological reaction to this pandemic as well. And the most studied and in fact worked out where those where stress was more was our own healthcare workers and the frontline workers, our children who are literally confined to their rooms for last 2 years, a special population. We had elderly, Dr. Samreen talked about the pregnant and lactating women. And then we have the specially abled population who don't have easy access to their daily needs, and general population. So literally everybody is at risk, and there are some risk groups which have higher chance of having mental health issues. So previous studies, as I said, would suggest that there were anxiety, depressive, and even post-traumatic disorder symptoms in patients who would undergo disasters, who would experience disasters. And same is being said about COVID-19 pandemic, particularly with the second wave demolishing everything around that way. The strict lockdown and the social isolation regulations have further added to the agonies of the people, although it's the only mode of getting your COVID numbers down. This has been complicated by the lack of knowledge about COVID-19. There is a lot of misinformation, what we call infodemics, all over the place. Everybody gives his own ways of countering COVID, which are at times true, but many a times very false things, which the people unfortunately follow, and they succumb to it. The lack of effective treatments, we have travel restrictions, and as I said, that there is huge economic losses going on around the world. So we have strict isolations, and more importantly, this wave of COVID in 2021 has higher mortality rates, and it comes in the severe form of COVID. So what exactly we have seen if somebody is COVID positive, and what does he go through? And it obviously depends upon the stage of COVID ward admission you are going through. Somebody, you, me, or anybody else for that matter, Maqbool Sahab said that he had COVID, and what was his reaction to the initial diagnosis, whether he would need admission or not. I remember he was very anxious and called me up whether I will get the facilities of admission. So this is then there is another setting that once you are diagnosed, yes, you are COVID positive, you are coming to the terms of admission, I need admission. And if you get admitted and God forbid your disease progresses, it is really a bad news for you. Then once you are okay, if you have recovered and you have pre-discharge testing, that adds more anxiety, whether it will be negative or positive. And once you are discharged and you face your family, you face your society and how they are going to react to it. So initially, once the COVID positive diagnosis there, as per our experience, who infected me was the first thing. How did I get infected? The anger was the first emotion. Then, second one, the guilt. Did I infect? How many people did I infect? Did I infect my parents, children? I didn't take proper care because I never knew I was COVID positive. Did I infect my spouse, my colleagues? The next stage comes, will I survive? Okay, I'm in the hospital, I'm in the ward, will I survive? Will I get a high dependency unit or a ventilator? So anticipatory anxiety comes into place, and you will have acute stress reactions, you will have anxiety, depression, and Mudasir said insomnia, one of the prominent symptoms. So during the stay in the hospital, the worrying thing is that there are so many videos circulating that one would have loneliness, he gets socially disconnected, socially isolated, he will have all the symptoms of depression, anxiety, and disturbed sleep, fear of progression of symptoms is there, you have uncertainty about the future, whether I will live or not, discrimination, they say, by healthcare workers, कुछ लोगों को अच्छी तरह देखते हैं, कुछ को सही से नहीं देखते हैं, feeling of not being cared for, मेरे को कोई पूछना ही नहीं आता है, न घर से न medical staff पूछ रहा है, you have to adjust to the new environment, you are leaving your cozy homes, going to the hospital where you have to be contented with dal roti and sabzi roti or rice. So you are really, you have a boredom, you have screen media addiction. Many of the people who are on low oxygen levels go on to screen and look for many things which are all negative about COVID and their progression of disease. Many a times the screen media goes out of order and they really get frustrated with this. So if there is a slight progression of disease, now you are admitted in a hospital or in a center, if there is a progression of disease, you fear that you might be going to die and you may need oxygen support, whether it will be available or not. You see people dying around you, you hear about it, and it furthers your anxiety. You see that seeing other patients being shifted to ICU, you yourself being probably, the doctor tells you that you are not maintaining saturation very well, you may need to go to high dependency unit or even on the ventilator. So you are seeing people dead around you, you stop making efforts, you feel that it's all over for me, it's helplessness and hopelessness that prevails now, and patient can go into delirium. So other issues that are seen during the stay in the hospital, that what if I die? What happens to my family? Who will be available to do my cremation? Because we have seen that there were instances that Muslims were being cremated and there were some Hindus who were actually buried. So will my last rites be done as per my religious beliefs? What's going to happen to my mortal remains? So there were some very tough these questions and thoughts going through the persons who were moderately or severely ill. Then those who were on path to recovery, they had apprehensions that whether my result will come positive or negative, and if it comes negative, I'll be out, fortunately. But how are the people going to react to me? Will there be a stigma once I go back to my society? What will the family members tell about it, that you had gone to this gathering, you had gone there to for a condolence meeting, you had gone to attend a marriage party or to your friend's party? So they would start blaming me once I go back. My neighbors may not discriminate me, he thinks about it. My employer might have fired me from the job and he may not allow me to join back. My clients who would come to my business establishments may stop coming to me that I'm still infective. So you may have to encounter a bad news that once I reach home, that one of our family members is already dead, or God forbid, my friend or anybody else is already dead. So once there is a recovery, that's a good news, but it is obviously, if it's a long COVID, what you call now, you may have depression, you may have grief of losing the near ones or dear ones in the family or with whom you were infected and you never had an idea for last 15, 20 days where they are. So guilt about themselves being responsible for their death, and you feel that he met me, I could make it, but he could not make it. So guilt about damaging the society per se or the family, then post-traumatic stress disorder. So what happens to the family members who are actually not able to go into the wards, and what is happening to our relative? So they are very apprehensive outside the wards, outside the hospitals. Somebody is in quarantine or in a hospital. His family is really in anticipatory grief that mortality is quite high. I don't know what is going to happen to my dad, mom, or brother, sister, or my friend. So what about the cost of treatment? Is the government going to do it themselves, or I will have to get remdesivir and go from pillar to post to fetch it? And guilt of not being in stay with the person who actually need it. If you have a diabetic father or mother, or God forbid, especially able father and mother who cannot go to washroom, you feel all the time guilty that maybe I may be able to help him or not. So we'll have stigma. You are very concerned about the future of the family, what will happen. And about the healthcare workers that we try to protect ourselves from the infection, but we are really at high risk, whether in OPD, emergency, COVID ward, COVID ICU, performing procedures, fear of contracting infection. So these are the most common symptoms, which I think Mudasir already enumerated. I don't want to go through them again. And the stigma, second part of my presentation, we know that there is an association between a person and group of people who share a specific disease like COVID-19. They are labeled, stereotyped, discriminated against, treated separately. You have experience of loss of status. And obviously, because this is a new disease, many things about this disease are still unknown, and you associate with this disease with only a specific group of population. Earlier, it was people from Asian descent, then who were traveling, then healthcare workers, then people who had friends and family with the disease, and people from in the quarantine, and people from certain groups and community, in fact, were also stigmatized. We understand that this stigma has a very bad effect on people, and you are denied of health care, they are denied of adequate housing, they are made targets of verbal and emotional abuse, they are excluded and shunned in the social situations. This can make actually the things worse because they don't come forward. That is what actually happened last year. Once a particular community was stigmatized, they did not come forward for testing, and that really added burden to the society, increasing the infection rate and the positivity rate. So you really need to be very careful. And then third part of it is that death during COVID times. There were horrible scenes last year. Few healthcare workers or very close family or friends were allowed to go for funeral prayers, and many a times a single pujari would perform the cremation. And the Khalid Saab from New York would be very familiar with the place of Heartland, Potter's Field, where the unclaimed dead bodies would be buried for last 150 years, and they would be mostly Civil War soldiers, stillborn babies, AIDS patients, because they never knew how the virus is being spread, and it might actually spread in our community. So it is a far off coast in New York where the unclaimed bodies would be buried in a very undignified manner by those who were the criminals or the prisoners. So same thing happened in India. We know that fundamental right to die with dignity embraced the right to decent burial or cremation. So we know the Chennai doctor's friend who had to run from pillar to post, get his friend buried. Pondicherry had dead bodies piling up in a hospital. There were piled up bodies now and then also in the Delhi hospitals. And you see 2021 as well, and you could see these horrible scenes, and you really have shivers down the spine that God forbid my end should not be like this. These are really hard times for every one of us to believe. So then there's a grief. We know that lockdown and confinement and lack of possibility to stand by for those who are dying, and we have 6 feet of, and now say that 10 meters of distance to maintain with. So one could not say goodbye to our friends and family who were admitted in COVID wards. And this obviously resulted in a lot of issues, and there we expect that there will be long-term consequences in the form of mental, emotional, and physical health, which would result in complicated grief. So what was the modus operandi we opted for in media here and through other modes of social media, that we need to have a time schedule with your family, with a breakfast, then a few study hours for students, our children, then lunch for together, all of us, and we can have prayers and play with our peers and read a book, storytelling, then exercise together, or indoor games, or gardening, or painting, or art, whatever the children like. And we should have an what I have to put it as mnemonic: A, B, C, D, E, F. A is adequate sleep of 7 to 9 hours, balanced diet, more of veg and fruits and fluids, less of salt and sugar and fats, no smoking, no alcohol, connect to friends, that is C. And D is devote yourself to social causes or to Almighty. E is exercise regularly. F means that if you are not getting help at all and you still feel stressed, you have to find a mental health expert, be a psychologist or a psychiatrist. And most importantly, the G, you need to get vaccinated. So awareness is very important to go out so that the stigma goes away. We have to be empathic. We have to correct the misinformation. We have to engage public figures. I'm sir winding up. We have to learn new ways to mourn. Fortunately, technology has filled in the gap. Our words matter on Facebook, on WhatsApp to our friends. Our telephone calls matter more than before. We cannot physically go and mourn our respected and loved ones who we have lost during this period, either because of COVID or not COVID. So we have to have a collective grief process. We are sure that we'll grieve together, we'll heal together, and we'll fight this COVID together. And we have positive and inspiring moments from Kerala, where Dr. Krishna, a lady doctor who whispered into the ears of a Muslim lady, La ilaha illallah, Muhammad Rasulullah, which every one of us aspires once we are nearing the deathbed, that somebody will whisper into our hands. With these positive notes coming from the non-Muslim to a Muslim patient, I think we need to have more and more improvisation in our etiquettes and manners, innovate, like we have online classes and webinars. Thank you to the organizing team, and introspection is the best way of doing it. Last but not the least, let's be hopeful, because Quran says, Almighty says in Quran, Inna mal usri yusra. That means after every hardship, you will have a smooth running. Let us hope for that. Ameen, summa ameen.
Thank you, Dr. Majid. Thank you very much. Now we have our last speaker of this session is Dr. Yasir Hassan Rathar, Professor, Department of Psychiatry, Government Medical College, Srinagar. He has done training in addiction psychiatry from All India Institute of Medical Sciences, New Delhi, and is currently in charge of the addiction unit of our department. He'll be talking on changing trends of substance abuse during COVID-19 in Kashmir. Dr. Yasir sir, please.
Thanks. Good evening, everybody. It's really an honor and pleasure. I'm pleased to be part of this webinar, international webinar, and sharing this platform with my teachers, colleagues, and my friends. So I'll be talking on this topic of changing in trend, changing in trends of substance abuse during COVID-19 and Kashmir. I have no disclosures to make. The objectives of my presentation will be, I'll be just briefly giving a historical perspective of substance abuse vis-a-vis Kashmir, and changing trend in substance abuse during conflict, managing de-addiction services in times of COVID-19, impact of COVID-19 and lockdown on substance use and substance use behaviors. Before talking about the current trend of substance abuse during 19, I will just give you a brief historical perspective. Kashmir, our valley, has been very closely located to the infamous Golden Crescent, where maximum which is made of countries like Afghanistan, Iran, where the maximum cultivation of opioid, around 90% of opioid is cultivated over there, and it has been happening since decades. But being so close to this infamous place, we never had, historically never had it. Opioid was never a problem for us. Neither substance use was a problem. But the only problem which we used to have was the cannabis, but it had a cultural acceptance and spiritual acceptance. And there were famous places called church takiyas, where social gatherings used to happen, and people used to take cannabis to have this sense of spirituality. It was same was corroborated by a study done by our own Professor Maqbool sir. It was a longitudinal kind of study. It was a study where they reviewed the hospital records of 8 years, and they found that around 189 patients had sought treatment during that period for substance use related issues, and 77% of them were cannabis related issues, and only few had opioid related problems, and the opioid which they have been using were mostly of raw opium. It was during the as the conflict started during 90s, and which affected literally all spheres of our lives. And research has pointed how conflict exposure can result in an increase in mental health issue problems, including substance use disorder. There have been several studies have been done in these conflict-like areas, like Afghanistan, Syria, where they have seen that conflict leads to mental health issues, including substance use, and reasons being negative coping mechanism and sometimes boredom or lack of recreational activities or some other factors associated with it. Till 90s, we had cannabis as main was the main drug of abuse being used. It was in early 2000 when polysubstance came into picture, and medicinal opioids were the drugs which were being used along with cannabis. And same was seen in one of the studies which we did. Around 91% were using polysubstances. And then in early years of these decade of 2010 and 2020, the heroin started coming in picture along with along with medicinal opioids, which was seen in this study. Along with during this decade, apart from hospital settings and substance abuse came into notice in these media section, and media started highlighting substance abuse in the Valley. So keeping this in mind, like the increase in substance abuse, increasing hospital statistics of substance-related issues, and media reports, and changing in trends, drug use pattern, somewhere all together created a need to actually know the in-depth situation of substance abuse in the Valley. So considering all these factors, we did a pilot study where we we did this pilot study in 2 districts, Srinagar and Anantnag, and there were some to know the prevalence and pattern of the substance abuse, and there were some alarming statistics which came into picture. The prevalence of overall substance dependence came to be around 2%, which estimated around 18,000 people, while as opioids was estimated to be 1.80, which estimated around 16,000. Heroin was the most common opioid, around 84% were using heroin, and 0.95% were injecting it. 57% of were using these opiates at the age of 20. So the age of insertion was declining. And around 37.7% were had a history of overdose, and 91% IV users were using heroin as the main drug. In this study, we also found that there was an economical burden because of this substance pattern, and we found on state, we found that the daily expenditure of consumption of opioids in these two districts was a whooping of 3.7 crore rupees. It was the daily expenditure on these drugs, which was huge. So this was a scenario of drug abuse in Kashmir before pandemic. So once pandemic started affecting our state in early 2020, March 2020, so we witnessed the lockdown. And already we were struggling with this substance abuse as a major problem, and which was unfortunately a ticking time bomb in Kashmir, for Kashmir. So now we were in a situation where we had to deal with two disasters at the same time. And to hit it, the first thing which hit was the our center, Direction Center, which was situated in SMHS premises, which is a 25-bedded hospital with all modalities for treatment for for substance use for substance issues. Like we have these OST, oral substitution therapy were there, and all rehabilitation facilities were there. But unfortunately, this center was taken over by the authorities and was taken dedicated as a COVID ward. So the first thing that was hit was our de-addiction ward. As we were already aware of the grave situation of substance abuse in Kashmir, we had to come up with an alternative to keep de-addiction services running. And knowing that it was the only center for such services, we shifted our services to our main hospital, that was Imhans, and we dedicated a ward, 15-bedded ward with us for IPD purpose, and admissions were done properly after screening for COVID. Like tests were done on regular basis, like RAT and RT-PCR for patients who got admitted. And we also started the OPD services in the main hospital for de-addiction. Our hospital statistics from last year reflected a huge spike in patients seeking treatment for substance abuse. And a good chunk of patients had to be put on OST as they reported IV use with high-risk behavior. If you see the timeline across a span of 8 years, the cases of substance abuse have increased multifold, and the figures are surprising and are a matter of concern. These are the hospital statistics of OPD services, and you can see that around 95% of patients who came for treatment were using opioids, and among them 98% were using heroin as the main drug, and 80% of them were using these drugs through IV mode, which is very dangerous, and it was contrary to the pre-COVID times. And heroin was taking over all the drugs, overshadowing all the other drugs. These figures are the of the patients who were admitted for during these during this COVID times. And you could see that there was significant number of patients had a history of drug overdose, around 35%, and around half of the patients who were admitted during these 1.5 years, were had history of hepatitis C infection, which was a chronic infection, and around 68% had a history of sharing needles and syringes. And the likely reason was that they were not able to get new syringes because of lockdown. And around 69% of the patients were first-time treatment seekers. So to know keeping this in mind that this COVID-19 was a novel situation and its impact on various domains was not clear. So we conducted a survey to know how this pandemic and lockdown was affecting the substance use pattern and associated substance use behaviors in our valley. So in this study, we enrolled around 200 substance users after the lockdown period. And the most significant statistics of the research which came into picture was that around 56% of patients were in age group of young productive age group, that was 20 to 30 years of age group. And around 40% were students, and around 50% of the patient had a good education background, which was again contrary to the pre-COVID times. And 36% had started or had relapsed during the lockdown. As we all know, COVID-19 is not just a disease, and it had other associated factors like quarantine, lockdown, isolation, physical distancing, disruption in our routine happened, which led to many factors responsible for substance abuse like peer pressure, boredom, family issues, and financial issues came to be in main reasons. The sample we had was more of heterogeneous group with first-time users, or patients who had relapsed, and or those who were taking drugs continuously. And it was seen that in those who were taking drugs witnessed a decrease in pattern of substance abuse. And the commonest reason being the less availability of illicit drugs due to lockdown. There was a chunk of population of substance users who reported an increase in pattern of substance use during this lockdown, and the main reasons were peer pressure, emotional stress, and financial stress. And in this survey, we administered this GHQ to know the stress level and among these patients, and we found that around 26% of reported major distress, and the likely reason was again isolation, quarantine, loneliness, financial strains, and change in family dynamics due to COVID-19 and lockdown. To summarize the trend from what happened from pre to post-COVID situation, it was seen that predominance of heroin use was there, and there was shift from chasing and inhalation to IV route, and there was high rates of sharing of needles and syringes, high rates of overdose events and HCV infection rates, higher rates of heroin use among people from good educational background, where majority of them were students. And there was high rates of new users and relapses. We had witnessed relapses also. I would conclude with a very disheartening yet true statement: Kashmir ain't same anymore. Thank you.
Thank you, Dr. Yasir. Thank you very much. Now, we'll be having a break of 5 minutes, and we'll be back, inshallah, for the second session. It will be moderated by our mentor and guide, Professor Mushtaq Margoob Sahab. Thank you very much.
Welcome back, everyone. And I hope you all had a great first session. I, as a non-psychiatrist, enjoyed a lot and learned a lot from the session. I would want to say that great kudos, accolades to our colleagues back in Kashmir. You are doing amazing work, and we just cannot say how grateful we all are to you. I heard a very good quote, Kashmir ain't same anymore. Actually, the world ain't same anymore. The world has changed forever. But I liked what Dr. Majid said. We're back to the basics, A, B, C, D, E, F, G. So we're back to that. So with that, I'll open the second session, which is a panel discussion. We already have some questions lined up. Please use the Q&A tab on the right side of the bottom of your Zoom. And it's an absolute honor for me to introduce Dr. Mushtaq Margoob Sahab. He's well known to most of us, and some of us have been his students, like me. He's former professor and head postgraduate Department of Psychiatry, Government Medical College, Srinagar, and Director, Institute of Mental Health and Neurosciences in Srinagar, Kashmir. He's an internationally recognized expert on humanitarian emergencies and disaster mental health. Dr. Margoob's research work encompasses a wide range of topics ranging from seasonal mood disorder to drug use problems and stress. Over the past 3 decades, besides behavioral neurosciences, the focus of his work has been on coping, resilience, and vulnerability following traumatic stress resulting from man-made and natural disasters in the developing world and its impact on individuals as well as communities as a whole. He's a member of several international professional organizations and has published extensively. Welcome, Dr. Margoob, sir.
Thank you very much, Dr. Seema ji. I thank you and also Professor Khalid, Jahangir Sahab for organizing this feast, academic feast, but at the same time, as Dr. Arshad talked about Darikin Darbar, a process. Normally nowadays we don't see each other, but you made that possible. We are again together because if you ask people to, we ask ourselves to be together the way we used to be, it would be going to Nawata, Kathi Darwaza, right? The place where from the majority of psychiatrists, excepting for Dr. Samreen Shahji, have been, we have been together. It would be from Hazratbal going to Nawata, right? People would tell you this would mean going to Lahore through London. But you have made it possible that going to Nawata through New York, Arbafield, for us to be together. Thank you very much for this. Now, seeing the contents, in fact, I was just making some notes. In fact, the team, excellent team and the hard work they have also done in putting together the evidence, which would provide, in fact, evidence-based interventions in the future also, because ours is a place which, when we talk about Kashmir and then we talk about disasters, I'm happy that we are taking it as disaster because there are many things that are going on, whether this is just a crisis. If this is a health crisis, you take care and then this gets reverted back. That has not happened. This is a complex disaster. Disaster usually impacts a locality, a community, a region, a country, or a few countries as such. This is a global disaster. So leaving that aside, but this is a very complex. In disasters, you have certain phases. But here it is complex. You see first wave, second wave, so considering that. But now, where we practically are at present is something where we will have to consider the antecedents also. Not only the impact. So all these presentations, in fact, have comprehensively put all those aspects together. I was just seeing as Dr. Mudasir, in fact, reflected, in fact, what was happening globally. But then, since about disasters and the Kashmir part, he has been, in fact, not only formally getting trained, we have been in the community and doing certain innovative things in the sense that this is the need in Kashmir earlier. This was now the world needs to be in the community. And that means when we talk about antecedents, that would also mean all behavioral aspects for us, behavioral and mental health professionals as such, which would, when we are talking about vaccination, we will have to focus on vaccination regarding behavior. That would be behavioral kind of vaccination, where people not putting masks. When they put, why do they become complicit? So we have our own kind of, in fact, a role, but that would be based on what we have, in fact, collectively talked about here. So obviously, depression getting several times more, PTSD also increasing, although I do agree with him that this is not the time when we can talk about PTSD, whether it is coming down or up, because usually within first 3 months, 8 months or 6 months of an event, we usually wait because that is acute trauma and trauma-related consequences. Then about bereavement, Dr. Arshad gave us actually a comprehensive, a commendable kind of all dimensions and innovatively what is being done. And what they did innovatively, in fact, when the whole, in fact, you didn't have guidelines, you didn't have other kind of, things to lead you, be it ECT, be it Dr. Maqbool's that innovatively sitting outside and seeing patients face to face, in fact, in the open, then telepsychiatry part of it, then doing certain things about stigma. So similarly, an excellent job being done in the community, in the periphery, is a prototype of that kind of a selfless and dedicated work is Dr. Majid. I used, in fact, the whole group used to call them Majid Junior. So I'll be referring here Majid Senior and Majid Junior. That would at least make the things clearer. So, in fact, there are certain things which one would like to know, actually. How are things going on with the small team in the periphery and representing the rural kind of intervention part of it? Similarly, Dr. Majid Senior, in fact, so nicely reflected actually the sufferings of across the spectrum, general people, professionals, and that coming to the level of as human beings, whether we are frontline workers or whatever labels are given to us. But then there are issues, there are problems with all the people who are fighting it out in their best way, as said. Dr. Samrinji made us also wiser about the problems of the wiring of the brain is different in ladies and in the gents, that we know. In fact, she reflected that part of it and then its impact as the caregiver in the family about all those aspects. So I think that would also help us in future evolving certain things, because Kashmiris as such for last 30 years have been almost every individual. I personally feel that even the circuitries must be changed and even DNA as such might be impacted with this what has been happening. Now, in addition to that insecurity, everybody is in a confused state as far as maybe policymakers or the common person, a lady in a rural area as such. Nothing is clear. But what they expect, we being doctors, we being medicos, they have never been, confronted with a situation where they are not sure about our own uncertainty about a problem, because it is evolving. It's a new problem. The pandemic as such has come in such a way that there are many things which are changing also. So they get frustrated, they get angry, but at the same time, we also get burnout. Then different aspects of immediately anxiety. Dr. Majid Jr. talked about the anxiety part of it, now with second phase. That is what we have seen from 90s onwards, in fact. Initially, we didn't see suicides. We didn't see PTSD up to 95. It was only, adrenergic drive, palpitations in the mid of the night from 91, 92 onwards as such. So here also we'll have syphilis, as we are talking about long COVID now. So considering all this, Dr. Yasir Saab made us really wiser about the changing, very dangerous changing trend of drug abuse. Is it only a negative coping? Is it that the substances are so easily opium derivatives, especially heroin? Now in kgs, 6 kgs, 8 kgs is something which is horrifying. This is a news which you will find in the newspapers, that it is being, and that too at a track or a route through northern part of Kashmir getting established is really something which really needs every stakeholder. And here is a knowledge, here is science, which can help all policymakers to other people who are associated with it. I think now this is the time that we get going with the questions. There are many questions. I wish that we had few hours, to get the detailed answers to all these questions. But anyway, I'll just, Dr. Arshad, there is a question for you. That do your virtual consultations comprise only of audio, that is telephone kind of consultations, or do you also provide video? And if it is so, video consultations, what is the ratio of, and is there any data available with you, please? Dr. Arshad.
Yes, they're both audio as well as video consultations.
Okay,
most of the video consultations were done by me personally, and they amount to around 7,000 video consultations now, encompassing around 3,000 patients. While audio consultations were done mostly by one that my whole unit did, and then the other units also were doing of their own the audio consultations almost throughout the year. Now audio consultations are, previously we used to do all the week. Now we are doing it on specific times, and there's a proper roster for those audio consultations for the residents as well as junior as well as the senior residents. And whenever they need a consultant's help, then they connect the consultant as well. So we thought of this tele as a learning to postgraduates. So they are the first contacts in audio consultations. They take history, and whenever they think that it's important to discuss with the senior, they do that. And when the senior resident thinks that it's important to discuss with the consultant, so he pitches in the consultant. So that way we did it. There were more audio consultation, much more, because they were done almost whole day initially, and you had more people actually getting connected. There were lots of non-governmental organizations which were pitching in as well. But the video consultation, as it was limited to me doing the video consultation, so their number was less. But the data which I actually showed you are mostly from those video consultations, because I was doing it through an app, so I was able to break it professionally, make diagnosis in every case. So that's why I actually relied on that data first, because we have not actually analyzed lots of the audio consultation data.
Excellent. Dr. Mudasir, somebody wants to know, that is post-COVID fatigue a separate entity, or it is part of long-term neuropsychiatric manifestations of COVID? We know that, in fact, this, as you explained, nicely explained it, but somebody is interested in whether fatigue alone is something.
I think the simple answer is I don't know. And looking at the studies and data is that I think we still are kind of in a phase where things are not quite clear. Long COVID is still coming up as a diagnosis. Fatigue is a symptom when the symptoms start, when the COVID starts in anybody, and then it can continue forever as well, or for months. So essentially, I think we don't know yet, but clearly, technically, I thought I would have a slide on long COVID, but I deleted it because of time reasons. But essentially, long COVID is essentially a diagnosis of exclusion finally, where you rule out the other things, and it's like a chronic fatigue type of situation. Which we already have a diagnosis. So essentially, is fatigue separate or not? I'm not sure, but maybe other panel members can help with that. I think there was one more question related to my presentation.
Yeah. That is actually post-COVID study you referred. Actually, was it only severe ones, or there were some mild or moderate cases also?
So essentially,
may I add to the earlier question first, so that you take up the second question, so that we continue with the earlier question? May I add something?
Please,
if I'm allowed.
Yes,
if I'm allowed to. One of our postgraduates says, actually, because ours, the hospital at SCIMS Bemina was a COVID hospital and is still a COVID hospital, almost literally for 1.5 years now. We had respite of around 4 months, and one of the postgraduates actually did his thesis on this only. So you are absolutely, I share your same experience that we are yet to compile the data, but initial reports as I see, initial observations as I see, that fatigue is one of the very important factors that we are observing in patients, particularly who had moderate to severe disease. There are other confounding factors like comorbidity, like lower socioeconomic status, or if there was a death in the family, because anxiety as such complicated the fatigue in the patients who are the survivors. Maybe it was survivors' guilt also, which is aggravating or complicating the fatigue. So these are the initial, I won't be able to reveal everything what we have seen, but these are the initial observations from our center.
Excellent. Yes, the next question.
So just to finish. Dr. Mudasir, well, Majid, you want to add something?
Sir, Arshad.
Dr. Arshad, yeah, please.
So first, the historical perspective to long COVID. If you late 88 or 89, there was a Russian flu, which is actually thought to be the coronavirus disease, and the fatigue was so severe in some countries, particularly probably Tanzania, that people could not do sowing and harvesting their hair, and it led to famine. So fatigue association with corona is a little bit old. The current definition of COVID actually does not talk about the symptoms. It talks about the duration and whether they are attributable to COVID, which means the duration of symptoms more than 3 months, and their attribution to the COVID symptomatology. As Mudasir rightly said, excluding the others. But the symptoms are not yet, decided. So symptoms have not been decided. So long COVID will be anything which lasts more than 3 months and cannot be attributable to any cause but COVID. But fatigue actually could be one of the major symptoms, looking at the history back of Russian flu, which actually was thought to be because of corona and the effects it had on the fatigue.
Excellent. Yes, Mudasir, yes.
I will conclude the second part of the other question is, so basically the study is mainly on people who were not admitted to hospital. Around 200,000 patients were not hospitalized. So they either had no symptoms or they had mild symptoms. So because they were all COVID positive, it doesn't say whether they were symptomatic or not. There were less than 40,000 admissions, I think 36,000 something. And out of that, less than 10,000 were in ITU or ICU. So essentially, the whole study is on people who had mild to moderate COVID, if that answers the question. So yes. So I think that is why it is worrying that still, despite the majority chunk of the people who were not hospitalized had mild COVID or no symptoms, they are then getting some kind of neurological or psychiatric sequelae in next 6 months is worrying for all of us. I think probably with time and with more studies, we'll know better. But clearly, I think there is something going on with the illness is more systemic than we think. And the brain seems to be a particular focus of it, maybe directly or indirectly, both ways. Thank you.
Dr. Majid Saab, Dr. Shaheen is asking a question regarding mental health services doing something in addressing actually the bereavement part of this people's sufferings. And in fact, there is also stigma and other things also associated with it. That is something being, but before you answer my question, this time we are seeing actually, maybe all of you will agree with me, that even our own fraternity members, doctors, are this time themselves in a dilemma at times when they feel that, yes, we are kept at times at the highest pedestal, that you belong to a noble profession, that you are supposed to do. And I have seen some of the fraternity members really saying, Dr. Please, since I am in distress, they opening the sentence, first sentence when they seek some help, so this is something which is a burden to me, that everybody expecting me to do something, but we are human beings. We need to be taken as other human beings, rather than making us next to God, expecting everything from us, but then feeling frustrated and all the anger getting directed towards this. So since stigma, otherwise that is a different story. As for last 30 or 40 years, we are also doing TV and other things. But this time, since this is a need, as Dr. Majid Jr. as such, what he is doing in the community, something needs to be done more in those areas as such. Maybe Dr. Majid will then add to your Majid Jr.'s comments. So first, bereavement part of it.
Myself, I need to answer.
Yes, please.
Yes, there are actually two parts of the question, if I understood it correctly, that it is about healthcare. One would say a care burden, particularly in those who are the frontline workers working in wards, be it isolation wards, be it high dependency unit, or be it the patients who they are attending who are on ventilators. Actually, let me share a small data of last 1 month only with you, which will I think make things clear that we had more than 300 admissions of moderate to severe COVID in our hospital, which is, again, I will repeat that, a COVID designated hospital. And unfortunately, we had 34 deaths. That makes it 10% of mortality, because they were all moderate to severe. And out of those 34 patients, only the good news is that only one was less than 40 years of age. Around 10 patients were between 40 to 60 years, and rest of the majority of the patients were more than 65 years of age. And most of the patients, I would say around 23 to 25, died within 48 hours of arrival in the hospital. So the main reason attributed was probably that they had very severe COVID. They did not report to the facility in the initial stage. Their saturation was quite low, and we could not revive them. The infiltration was so bad in the lungs, and other systemic ailment was so much advanced that we could not help them. So second important thing is that once you have, whether it's a consultant, whether it's a senior resident, whether it's a junior resident who are on duty, it depends upon the specialty he belongs to, which I have observed personally. Somebody is working in emergency or trauma medicine. Somebody is working in medicine or chest specialty. They are used to declaring patients in emergency medicine almost every day. But somebody working in psychiatry, dermatology, or ophthalmology, for that matter, they are not used to mortality at all. In my presence in last 12 years, I think we had one death only in ward who died of MI because of certain reasons. So we are not used to mortality at all. For us, it is something very different. So what ideally I advise my rest of the consultants to do is that at least prior briefing to the staff who are not used to encounter these high level of mortalities in such situations. Second thing was, very important thing was that if somebody developed healthcare issues, which some of our nursing staff developed, particularly who had issues back home also, or health-wise also, we gave them layoffs. I recommended, and we as department recommended, that you should, instead of giving 1 week layoff, those who are suffering actually should be given at least 2 weeks layoff, and they put in an preferably and lower intensive sort of a care, so that they can ward off their emotions, and they can have a sigh of relief. Third important thing is talking to them. With the senior residents would talk to the senior residents of other departments. So there were the things which were done to at least relieve the anxiety among our healthcare workers. Second important thing, the second question which was put to me about the stigma, as you said, sir, in people who are, and all of us, in fact, I will not tell about myself only, be it my colleague, Dr. Arshad, Dr. Majid Jr., as you said, the other Majid, and other people, Yasir, and everybody is literally on media, Maqbool Saab, everybody is on media talking about the stigma associated with it, because I think the psychiatrists know much better stigma than any other specialty in the world. We know that mental health is being looked down upon, and so was the COVID patient being looked down upon. I think it was our responsibility, our moral duty to make people aware, and we did our bit. We did our bit through media, whether it is audio, video, or even through the social media, which is quite very much watched, and we countered the narratives that were built about misinformation, misconceptions. We tried to just counter it in a very nice and professional way, and we have been continuing it till now.
So may I say a word about bereavement? Shyness. Sir, with your permission?
Please, yes, please.
Dr. Shine, you would be pleased to know that Institute of Mental Health and National Rural Health Mission, we have started a project from 2 months. In fact, it's a thesis of a postgraduate and a project of where we have complete data of every death which has happened because of COVID in Kashmir, and all of those families are being accessed for time being. 3 families till now have been got for family sessions and grief resolution. The process had started just before the second wave started. As the second wave started, we have gone a little bit slow. We're continuing with the assessment of these families, which is done very professionally using standardized tools. And then wherever we feel that intervention is needed, we either will do it online or we can call them in offline modes in the hospital. The 3 families we got were really in bad situations, and we had to actually call them to the hospital. Most of others, particularly the people who have actually, the bereavements have happened post-August, seem to be more settled. But as Majid rightly said in his presentation, the bereavements which happened in the initial period have been very, very traumatizing. And these were from the initial period. We're continuing this assessment. I think in the next 6 months, we should have assessment of all the grief-stricken COVID families. And inshallah, we should be ready to share that data with you as well.
So may I add something before you go on to next question?
That's why I just wish that we had hours and hours together. Anyway, you will have to just briefly tell me something.
I actually share with you a family who actually are based in Lucknow. They were a Sikh family, Sardar family. They had migrated to Delhi recently, 3 months back, because they thought that COVID is settling down. Their son was doing a job in multinational company. And unfortunately, while getting exposed on the job, he lost his son. The family lost their only son, 27 years of age, followed by death of grandmother as well in the family. And this was due to lack of oxygen as per the family. And believe me, the rest of the family, the father, mother, and the 2 daughters and the son-in-law had migrated to Srinagar, got admitted in the GLNM hospital because of lack of facilities in Delhi. So they survived, but the father had a lot of guilt about not being able to shift the son to Srinagar as well. Plus, the father was in complete denial that COVID is something, a disease. He would tell his son that this is all rubbish, this is a creation, it's a political conspiracy, forget about it. Now he is so much in guilt, so much disturbed that he feels he is the person actually responsible for the death. So the 2 daughters who had only one brother to rely on, to put their shoulder and cry on, is no more. So we say the stages of death, that is denial, anger, bargain, depression, and acceptance, they are varied in all those 4 or 5 family members. So it's a very complex situation, and doing things, as Arshad said, I would say that it will be a tough time, I feel, for most of us dealing with such a scenario in future.
Thank you. But as you also said, فَإِنَّ مَعَ الْأُسْرِ يُسْرًا, इसी तरीके से, same way, नाउमीदी कुफ्र है, right? Any situation we face, we are never going to accept that helplessness and despondency. We have to exert, and all of you would just agree with me and bear me out that when we didn't have resources, we used to do certain things which might not have been, verified or even documented as evidence. By that time, we would be connecting with the people. So here also, I would just stress that now that you are doing so many things, put it together. This would be just a suggestion. And then, because there's a next question that is about what are you doing about the media part, social media part of. Many a times certain things are getting created in such a way, then you are the people who are actually experts in addressing that. So what I would suggest here, since earlier also when there was nothing in the field at district level and other things were getting extended from a central place of Srinagar Institute. But this time, alhamdulillah, now that we are at district levels, and that's why I would go next, comment from Dr. Majid Jr. to elaborate a little bit, because he has shown some slides doing certain activities in this direction. Is it possible that you formally do something in this direction almost on a regular basis in media, so that would again come to the same vaccination part of it? Social vaccination would be actually the answer, where we have to work on this, and maybe it doesn't help only in Kashmir, maybe like earlier, smaller, humble kind of efforts have actually helped us in, maybe helping other people at other places also. So this is something where you have enormous burden on account of previous so many things. So please, Dr. Majid, can you just elaborate a little bit? What are the difficulties that you are facing in extending the mental kind of, health related, getting them addressed? And how do you engage the other stakeholders, be it imams, be it teachers, be it all other people who really matter in the community if we really want to address it the way it ought to be? Dr. Majid.
Majid probably has some connection issue. He just got disconnected.
Any of you who wants to just elaborate on this?
It's very actually probably you said that COVID might be purely a biological illness, but the treatments are still behavioral. Whether it will be the behavioral modification forms of certain behaviors which people have to follow, or the behavioral interventions need to be done at various levels to actually prevent the pandemic. There's absolutely no doubt in that. We are still in 1912. Nothing has changed. The behavioral intervention was needed then, and behavioral intervention is, and probably no better than mental health professionals to actually do that. There were certain impediments to that. Majid actually. Both Majids, they have done wonderful job actually. Both of them actually have talked. I've seen their videos lots of times. Have talked about these things on media and at other places as well. Majid was in the field as well. He went to the isolation centers. We were in touch, and he worked from there as well. In fact, I wanted him to do that through telemodes, but the deputy commissioner wanted him to actually go, so he went there, and keeping social distance, he actually did it. But what happens, sir, some of the impediments were because once the lockdown started easing out, all of us got sucked again into our own work related to our hospitals, because that was too huge. So it was really difficult to actually balance between the two. But as you rightly said, sir, we could use social media, because that's much easier to actually continue creating this awareness. I tried my bit by using it at various points of time. And let me tell you that people do take us very, very seriously regarding those issues. And many people did actually change their opinions about various things after they read talked to a psychiatrist. I read a psychiatrist when they said that, you need to actually do these things. Consider, for example, my tagline was always that if you want to decrease mental health morbidity, you have to decrease mortality and morbidity because of COVID. And that means you have to do masking, you have to do social distance, you have to keep yourself clean. It's linked to mental health, because once mortality and morbidity increases, then the mental health will come. So mental health has to be effective. You can't prevent it from coming. So per se for mental health, we actually started doing that. We could actually do it in a more coordinated way. I think there's a scope for doing it in a more coordinated way.
Thank you. Thank you very much. Dr. Samrinji, there are a few questions which I will just club together regarding some tips about the ladies, because you talked about, comprehensively about the burden and about the problems that the ladies are facing. So specifically in the context of Kashmir.
First thing I would say would be involvement of more and more female psychiatrists on such forums. Women should have the choice to be able to select their psychiatrists. So I have seen that many times women, especially who have had sexual trauma, don't connect well with male psychiatrists. That's where I would lay emphasis on the involvement of female psychiatrists in inpatient as well as outpatient work. And social workers, I think, would be a huge asset which could reach out to women, especially in the rural areas where we know women are already overburdened with so much, and them taking out the time and then going to a psychiatrist's clinic or seeking help for mental health, it seems like a big issue. So if we could have psychologists and social workers involved who could reach out to women in such situations, I think that would be very helpful. And ensuring, which I feel really, because it's very difficult for women to talk about certain issues if they are not, provided a safe environment a woman may not be able to share as much unless she is really assured that this information is not going anywhere. She is in a safe place and she can discuss things with her mental provider. So those are the things I think we should really try to work on to provide a safe environment to them to come up and talk.
Thank you very much. We have earlier not had, you would be very happy to know that the Institute of Mental Health and Neurosciences, as well as Dr. Majid, are training psychiatrists, but we have about 24 psychiatrists who are getting trained at Institute of Mental Health and Neurosciences. Dr. Maqbool Sahab, Arshad Sahab, and Dr. Yasir Sahab are there from the faculty who are training them comprehensively. And now we have enough of them, one. Second, that earlier we didn't have it.
There are some issues, connection.
That's fine. We can move on to the next question till Dr. Maqbool Sahab comes back. We can take a few questions. How is vaccine hesitancy being addressed in Kashmir? Is there any data on the prevalence of delirium in elderly affected by COVID? Anyone can take this question since I don't know how to direct.
Vaccine hesitancy, I think not much concerted effort was initially, and there was lack of fear as well. But I think vaccine hesitancy has been just taken away by the fear. The second wave has just taken away. I'll tell you that in our hospital, the vaccination, when on any vaccination day, the 10 vaccines will be supplied, not all of them will get consumed. In fact, 7% of all vaccines got lost in Srinagar. But today, 100 vaccines came and you had a 300 line actually waiting for them. So vaccine hesitancy had just vanished because of the kind of second wave which came. The next part, you said about the post-COVID. Yes, we do have data. Probably we were from Kashmir, we were probably one of the first to actually talk about post-COVID delirium. We started talking about it in April. That time we had around 7 cases of post-COVID delirium. Now we have around, I think, 49 of them enrolled post-COVID delirium, and some of them are persisting with dementia. As we see, they're all from the first wave. We have not actually enrolled those cases which we have seen in consultation liaison clinic in the second wave. That's the data currently which is with us.
Thank you, Dr. Arshad. Next question is, hi, I am a mental health counselor. As we know, large number of people are having mental health issues, disorders, and are being diagnosed and doing well. Now, what are the measures to save them from COVID-19 negative effects? I lost it. Where did it go? Negative effects, so that there are more chances of getting involved in mental health issues may reduce. So someone who's recovering from some stress, how do you prevent further stress or relapse in them?
Dr. Majid, sir.
Me? Okay.
Ji.
Thank you very much for directing it to me. Anyways, I think what I said earlier, that time schedule has to be set in the family, that anybody for that matter, whether it's a COVID affected family or not affected family, a time schedule has to be stuck to where every person around in the family has an adequate sleep. They get up in the morning, can have prayers together, can have breakfast together, and the students can be, the children can be guided online by the parents itself or the teachers themselves, and then we can have lunch together and prayers together. That is how time schedule could be set. And second important thing is that ABCDEFG, that can be followed in letter and separate, which actually will reduce the chances of our stress, be it adequate sleep, be it you have a balanced diet, then you connect to your family, friends, maybe virtually only, physically you connect to your family. This is, I think, the opportunity for all of us. We hardly see our family members, particularly kids. We get back to our home and our kids are sleeping already, second day ready for the school. So now is the time that we can connect to our families better and connect to your friends and the people around the globe virtually, and then devote yourself to the social causes. There are many, many people who are in need of your help, be it financial or otherwise, and devote yourself to Almighty Allah as well, and exercise regularly. You may not not have a big gym outside or inside your home, but you can have a stroll around, you can move around, then obviously find a psychologist or a psychiatrist through telephone or even through video call, and if you can visit physically also, that would be okay. And importantly, as I said, please get vaccinated. That will take most of the stress, because you have no other option. If you have COVID, you have likely chance of getting very badly affected or even die. But if you have vaccine, you hardly have any report of death. So I think the better choice for all of us would be to take vaccine rather than take COVID and give opportunity for this virus to get into your body and into your family.
Thank you, Majid. Absolutely agree with the vaccine and agree with the A, B, C, D, E, F, G. Next question is, hello, my question is that most of the people are suffering from anxiety in nowadays of lockdown. So please mention some mental health tips to cope up with the anxiety in the pandemic. I think we have addressed that. If anyone has anything to...
Seema, I have one thing to add. We have addressed that, and this keeps on dropping. All of us are anxious, all of us are sad. We have to realize one thing. These are survival times. And we have to accept first these are survival times and not extravaganza times. All times in human beings' lives are not about enjoyment. We have become, as human beings, we have evolved to being too much dependent on external factors to be satisfied, to be content, to be happy. That thing has to go. You have to think of human beings as people who can have sadness at times, and they have to accept that sadness, which is very, very essential for them to actually survive. We as human beings are surviving on this earth merely because of this fact that our ancestors at various points of time thought of periods as survival periods and continued doing very hard things. Some of them did not come out of cave for years at the Ice Age time. That's why we are surviving here. So think of it as a survival time and do everything else which is possible. That will make you to accept it. It's not always essential to be happy, to have happiness outside. That has become dependence for us. We become happy through the external means. Try to get that happiness inside. Accept that survival.
Dr. Seema ji, thank you very much for coming in and supporting like this. But this was a classical example of not only life in Kashmir, this is happening all over the world this time, but they have experienced it only for a few months. Otherwise, we human beings would think that we would plan for not days, not months, for the whole lifetime. It is not happening because of COVID. Others are experiencing it, but we in Kashmir, this is how our life goes. So anyway, we are talking about these dimensions of uncertainty, insecurity, and everything connected with that part of our mental health at individual level and collective level. Anyway, I would just like to have some inputs from Dr. Yasir Sahab about this negative coping and with this changing, frightening, scary kind of drug-related intravenous kind of part of it. So considering it with the previous, we did have earlier also opiate-related kind of problems, even in 80s, in fact, that pattern changed. But now this horrifying kind of a thing, what really you feel needs to be done, one is wishful thinking that you would expect, in fact, you see this agency, that agency, leaving that aside. What do you think needs to be done and could be done with kind of other stakeholders involved in the community as well as we professionals?
Actually, it's not a single man's job, and it doesn't have a single answer. So we need a collective effort, and all stakeholders need to be taken in confidence. And in fact, we have drafted this drug policy also, where we have defined roles of and responsibilities of all stakeholders, including health department, school education department, and the police department, crime branch, and excise department, where we have defined the roles of every department. Because there was something which you are also aware that there was something everybody was trying to jump in, and there was confusion of jobs. some departments.
Anyway, yeah, that's a very lengthy discussion on that, but it is a fact that yes, these policies and other things as such look good on the papers. Now you would have also national drug kind of policy. You did have it in Punjab and other things. That is true. Then we know other aspects also of this, but just a question related with now that people were seeking treatment in a general hospital. That is the reason we tried our level best to establish it there in the general hospital, because one of our research years back, that was 90s, had shown that one NGO sort of thing being, supported by Social Welfare Department, Mashwara in Jammu, the follow-up, we carried out that follow-up. The results were much better there because the patients were drug abusers or users were actually taken care of as separate kind of in a setup. While as at our place, in fact, the failure rate was 75%, more than 75%, we'd seen them for 6 months. So based on that experience, now that we have shifted from SMHS, a general hospital setting where you do need physicians, you need other people also. And now, do you find a change? What was happening in the profile of the patients and their quality of life when it was being, services were being rendered, delivered there in the SMHS and general hospital setting, and now we are doing it here?
The general hospital setting, which you have commissioned, I still remember it was in 2011, you started that services, and it really helped a lot in coming out. There was a lot of stigma attached to the substance users. Yeah, and the unit which we started in SMHS, it helped to overcome that stigma, and it integrated the de-addiction services into the existing medical health services. That's what was needed to overcome the stigma.
Now, do you find any change in patients seeking treatment voluntarily coming forward compared to that place? Yes.
And I think the kind of addiction we are right now having, as I mentioned my research also and the presentation, that the trend is really, the trend is of using of these heroin IV use is it's very dangerous and has a lot of complications, medical complications associated with them, like hepatitis C and other complications like infections of endocarditis, sepsis. So integrating these services into the medical structure, existing medical health structures will help them a lot, and it will help in destigmatizing the whole problem.
Now that you have been seeing these patients here in Institute of Mental Health, Badawari, that is something people want to know as such. Is there any difference in hesitancy in people coming to this place because of its location, stigma, and other things? Or no, you don't find that? Rather, they are forced under present circumstances.
We have come a long way. We have come a long way. The psychiatry hospital is not the same what it used to be 20 years back, and it's all because of hard work of seniors like you. Colleagues like Dr. Arshad, Maqbool sir, and this psychiatry hospital has come a long way. It's like any other institute where it has. It's
very heartening. It's very heartening. Of course, one had to face, in fact, those days, even letters from so-called higher authorities that I couldn't change the name. Arshad couldn't then change the name of this place because then we were violating things. I am not talking here about that. What I wanted to know is there are certain things. Has the perception among people also changed? One, as far as drug abuse is concerned.
I'll chip in here, and I think that will settle. So there is, so the problem is so big now, and this is the only place where they get admitted. That's making them to come and take this treatment. Given a choice, given an option of having that in SMHS, they will allow to go to SMHS. I think just because there is no other option to go, and then they see the facilities there. After they come there now and sit there, then actually the thing is that the stigma thing probably goes. But otherwise, at the beginning, once the option is given, you'll be admitted in SMHS, they will take it. I think lots of parents actually think that SMHS was better. We have Dr. Yasin has some audio issues. He was not able to listen to it properly. So we talked to Dr. Yasin and we talked to him about it many times.
We'll have to,
Yes.
We'll have to just wind it up. I thank everybody who has been there listening to this long discourse. I think everybody has benefited or at least had some tips from the people who are really working in the field at different places across the continents. And we hope that this activity will continue, inshallah, something at individual level, collective level, and under the patronage of Dr. Khalid Sahab and all other members like Dr. Mudasir are doing in UK and other places. Thank you very much. Now I invite Professor Khalid Sahab for his kind words, remarks, and concluding the session.
Wow. What a wonderful expose of such a difficult subject matter today. I can't believe the ease with which all the speakers presented their work and the sophistication that the moderators exhibited is really a testament to their commitment, knowledge, and experience in their field. Thank you, each and every one of you, for exemplifying the true spirit of dedication and commitment to your community and your profession. It is really, really, truly appreciated. With your presentations today, we have, and I certainly have, a better understanding of mental health during this difficult time and the prolonged lockdowns imposed on people because of the epidemic. We have a better awareness and realization of the value of mental health experts in the society, which sometimes we really do not recognize and certainly do not appreciate. And of course, the researched evidence of the harms of confinement and the pandemic, especially during periods of conflict, on the mental, emotional, and spiritual health of individuals. Truly, we are so grateful for your service and service to our communities. God bless you. And to remind those who are interested in claiming the CME credits for this activity, you need to complete both the survey evaluation as well as the CME attestation in order to receive CME credits. Our IT staff will put the information in the QA box for you, and it's also included in the flyer and the pamphlet that was distributed previously. And this really leaves me with final thank you to the organizing group, to the sponsors, to the moderators, and of course, to you all who participated and joined in today's program. We are delighted that we had a large number of individuals that joined in across the continents to be part of this program. We hope to do similar programming sometime in the future. And with that, be safe and have a great day. Thank you again to each and every one of you. God bless you.
Thank you. Thank you very much.
Thank you, sir. Thank you very much. Thank you.
Thank you, sir. Thank you very much.